Buenas and Hafa, the Committee on Health and Veterans Affairs Oversight hearing of the Guam Memorial Hospital Authority is now called to order. The time is 9:08 a.m. and today is Wednesday, March 19th, 2025. Thank you to everyone joining us both in person and online for this hearing. Notice of this hearing was provided to senators, stakeholders, and the local media on March 12th, 2025 and March 17th, meeting the requirements of the open government law. In addition, notice of this oversight hearing was also posted on the Guam Legislature's website and the Guam Public Notice Portal. Materials for this hearing were shared in the committee drive and are available for print upon request. Recording of today's hearing will also be available online via Guam Legislature Media on YouTube. I would like to acknowledge and recognize the committee members present here today: Senator Jess Lujan, Senator Sean Gumatautau, Senator Tina Munoz-Barnes, Senator Vince Borja, and Senator Chris Duenas. Also joining us today, Senator Therese Terlahi and Senator Chris Barnett. Today we are here to hear directly from the executive management team of the Guam Memorial Hospital. We will be presented with a lot of numbers, hiring policies, staffing patterns, dual duty contracted physicians. But before we get into that, I want to make one thing absolutely clear. My number one priority is to improve the quality of care our people receive the moment they step into the Guam Memorial Hospital. Right now, I'm tired of the new hospital dominating the headlines, because what's not dominating the headlines is the fact that since I took office in January, we have been faced with devastating allegations of patient neglect, computer glitches, tragic deaths, and allegations of financial mismanagement at GMH. I've only been in office for a little over 2 months, and GMH lost $10 million out of $20 million in ARPA funds because, according to BBMR, it didn't follow U.S. Treasury guidelines. GMH lost its internet and Wi-Fi capabilities and was almost unable to pay its more than 1,000 employees because of a power glitch. In February of this year, a wrongful death complaint was filed against a doctor and GMH, alleging gross negligence that led to the death of a newborn. Recently, an audit was released by the OPA regarding physicians' pay and cited numerous instances where some doctors were being paid as government physicians and GMH admin staff and then paid as a contracted physician. Just this past weekend, a woman was found unresponsive in the hospital courtyard after supposedly being discharged earlier that day. The Guam Police Department is currently conducting an investigation. Just the other night, I was contacted by a family who shared yet another tragic incident at GMH, which was also reported by KUAM last night. This is a summary of their statement. On February 4th, 2025, at approximately 7 p.m., my 75-year-old uncle, who was disabled and oxygen dependent, was admitted to the GMH emergency room due to severe back pain that triggered his anxiety and shortness of breath. He was escorted by my mother, his point of contact. By 8:30 p.m., he called his sister in distress, saying that no one was checking on him. Between 8:45 and 9 p.m., we returned to the ER to check on him. He asked for his Lycodane patch, which my mom placed on his back. He looked sleepy, so we left, assuming he would be admitted as usual. At approximately 12:50 a.m., my mother received a call informing her that my uncle had been found unconscious outside the hospital near the guard shack. When we arrived at GMH around 2 a.m., the doctor informed us that life-saving measures were attempted but unsuccessful. We were told that my uncle, a disabled man, had somehow rolled himself down the ER hill in a GMH wheelchair and landed on the ground in front of the guard shack. Staff claimed that he was discharged after 10 p.m. and that family was contacted to pick him up. However, another version of the story suggested that he called his own ride. These accounts were inconsistent, and there was no record that any calls were made. Instead of answers, we were met with denials and contradictions. Now, this raises so many questions for me. For example, where were the security guards? How does an elderly man, disabled man, wheel himself down an incline, over a speed bump, and discovered hours later dead in front of a security checkpoint? This is unacceptable. Beyond these reports, there are serious concerns about basic hospital operations, and here's just one example. This is a NICO tab. It's a simple electrode sticker used for electrocardiogram ECG procedures. According to a physician that I spoke with, GMH recently ran out of them. A local clinic had to donate boxes of these stickers because the hospital didn't maintain an essential medical supply. A box of these, I'm told, it's $7 for a box of 100. This is not about money, although they will tell you it's about the rising cost of healthcare and the fact that they cannot turn anyone away. But no matter how much funding we allocate to GMH, it is not fixing the problem. The real issue is the culture of mismanagement that has been allowed to fester for years. If we truly want to improve healthcare for our people, we must stop looking at GMH as a problem we keep throwing money at. Instead, we need leadership that demands accountability, prioritizes patient care, and ensures that no family has to suffer because of the hospital's negligence. This oversight hearing is not about numbers, it is about lives. The time for excuses is over. It is time for real change, and it starts with management. Just yesterday, I participated in a meeting with OFB and the hospital's executive management team, and we were asked to appropriate $54 million over what the governor's budget requested for the hospital. This $54 million request included over $20 million in CIP. The reason why this is difficult for me is because GMH had $20 million in ARPA funds to cover CIP projects. $10 million of that was used to pay vendors. The remaining $10 million, according to BBMR, was sent to the new hospital fund because GMH failed to meet US Treasury guidelines. Let me be clear, I am not saying I do not want to work together, but I am saying y'all need to get it together. My committee is not going to give money if it cannot be properly managed. Again, I have been on the job for a little over 2 months, and my phone has been blowing up with messages from doctors, nurses, employees, and patients that are fed up with the incompetence. Matter of fact, I just took a call about an hour before this oversight hearing from yet another employee at GMH frustrated with management. Incompetence isn't even my word. That is the word used from people working at and seeking help from GMH. So over the next few hours during this oversight, I am hoping for complete transparency and honesty. Today, we expect hospital officials to provide answers regarding the following issues: Guam OPA Performance Audit Report number 2504, Guam Memorial Hospital Authority Contracted Physician Compensation Package and Privileges, Part 1, Contracted and GG1 Physicians. Hiring practices, technology upgrades, electronic health records system, billing and collections, accounts receivables, federal grants, capital improvement projects, and current detailed staffing pattern. At this time, I ask all invitees and participants in today's oversight hearing to state their name and title for the record, beginning on my right.
Vincent Dueñas, the Supervising Accountability Auditor with the Guam Office of Public Accountability.
Benjamin Cruz, Public Auditor.
Kwasiyame, Neurosurgeon, Chief Medical Officer.
Yuka Hechanova, Guam Memorial Hospital, Chief Financial Officer.
Jordan Pauloon, Hospital Legal Counsel. Rodalyn Gerardo, Assistant Administrator of Operations.
We'll begin with representatives from GMHA as well as Public Auditor BJ Cruz and Public Office of Accountability employees. They'll be fielding questions from the Committee on Health and members of the 38th Guam Legislature. After testimony and question and answer portion have been completed, I will open it up to comments from the public, giving each speaker that wants to speak about 5 minutes. At this time, I ask the panel, or if you anticipate answering any questions, to rise and be placed under oath by the Sergeant at Arms. Mr. Zaldi, will you be testifying? You're the acting CEO. Okay.
Please raise your right hand. Under penalty of perjury, do you all affirm that any and all information you provide today, whether it be verbally, electronically, and in writing, be the truth, the whole truth, and nothing but the truth? Madam Chair, you're under oath. You may proceed.
Thank you, Sergeant at Arms. The rules of conduct. Individuals speaking shall only use respectful and professional language and conduct. Personal inference about the character or the motive of any senator or any individual is not permitted. The chairperson of the committee may order the removal from a hearing of a committee or subcommittee of any person who is not a member of the legislature and who fails to observe proper decorum according to the 38th Guam Legislature Standing Rules. Please provide written comments and presentations to the committee staff for photocopying. Once you have completed your testimony, please remain in the room for questions or additional comments as may be desired by members of the committee. All must abide by the rules of conduct for quality assurance standards. Thank you for your understanding and cooperation. Each senator will be afforded 10 minutes to ask questions and make comments. These time limits allow for a structured and efficient discussion while ensuring that all voices are heard. I encourage all speakers to be concise and mindful of time so we can accommodate as many perspectives as possible. Public engagement is the foundation of good governance, and your insights are invaluable in shaping policies that best serve our island. We will now proceed with a presentation from the Guam Office of Public Accountability on Part 1 of their audit into physicians' pay.
Thank you very much, Madam Chair. Members of the committee, when I took over the Office of Public Accountability in 2019, late 2018, early 2019, we were already confronted with a number of complaints about the hospital. There were whistleblower. We have a hotline, and we get whistleblower complaints or information almost on a daily basis. I mean, a weekly basis from that. We have a Xerox line. I mean, a line just for this at the office. It's 475 audit. 47 audit. 47 audit. The physician's compensation was something that we were considering for our first audit plan in 2019. We were going to include it in the 2021, but then when COVID broke out, I didn't want to have to do anything with the hospital. I just figured let this run out. After COVID was over, I felt I had put it off long enough and that we had to address the issue. This first audit is very simple. It may be 100 pages with all the appendices. There may be a lot of numbers, but really seriously, it breaks down to simply this. With the first slide, please. The objective of this audit was to determine whether, 1, GMHA complied with applicable Guam laws, rules and regulations in the hiring process of contractual physicians. 2, the hiring process and determination of compensation are covered by written internal policies and procedures and fee schedules. 3, if the contracted and hired GG1 physicians are covered with employment agreements/contracts. The audit was conducted in accordance with generally accepted auditing standards, GAGAS, and was focused on evaluating GMHA's compliance with relevant law, regulation, and internal policies. Our findings, if you'd move it to the findings page, next one. Our findings, one, the claim at GMHA was that GMHA physician hiring was not subject to Guam procurement law. However, according to GMH, it was governed by its own internal regulations. Two, we found that there was a lack of general or specific internal policy to govern the contracting, hiring, and documentation process of physicians. We found no internal policy regarding the use or applicability of employment contract agreements, such as professional service agreements, PSAs, unclassified employment agreements, UEAs, and memorandum of understanding, MOAs. GMHA, in one of our conferences, admitted, we don't have a specific policy. We have been crafting it, and we're going by how it was practiced. That was the quote that was given to us. But we found, the Office of Public Accountability found that GMHA had specific policies which we believed were applicable to GMHA's hiring policy. Next page. Under the law, GMHA was created in Title X, and in that law, in section 80.0013, the first paragraph there reads, the board shall establish and administer rules and regulations governing the compensation and classification of health professionals of the hospital. In the interest of time, I'll skip the rest of the sections, but you can see that throughout there, they make mention of the fact that this includes physicians. But it was the position of the administration of the board, the managers, that there was no specific policy. But we found that Guam Memorial Hospital in 2018, the most recent one, policy, was policy 8650-1-0207, which was for contracted staff off island, and it was effective August the 29th, 2018. The next slide, please. If you read the first line, it is the policy of the GMHA that all is there, all employment agreements, contracts shall be presented by the Personnel Services Administrator and or any division head or the HR board, to the HR Board of Trustees Subcommittee for review and justification of all employment agreement contracts to seek recommendation for approval by the HR Board and Board of Trustees, General Board, for concurrence approval prior to routing any employment contract. The Personnel Services Administrator shall prepare a transmittal letter which shall accompany the employment contract to the following agencies for clearance and signature: BBMR, AG's office, Governor's office. Contract staff shall meet the same service personnel requirement and are placed in place for the Guam Memorial Hospital and its direct employees. All new hired contracted employees shall comply with GMH policies, rules, and regulations. Please note that this was adopted by the board in 2018. and it says all. There's no exception. Those of you that in the legislature understand when you pass legislation that says all, it means all. And if you're going to have an exception, then you say except for. The board knew how to do that because if you read through the rest of the section up on top on the statute, there are exceptions for certain things that can happen to doctors and to others. We found that this 2018 policy was also followed up by an even more recent policy adopted during this administration, and this is policy A-LD 700, contract management, and this was effective July the 23rd of 2021. Next slide, please. And this 2021 policy reads as follows. It is the policy of the GMHA to enter into contractual agreements with qualified organizations, vendors, or individuals in order to effectively recruit or procure medical, comma, administrative, comma, ancillary, comma, personnel, comma, and other services as are necessary for the operation of GMH facilities. The department requesting services through a contract shall categorize the proposed contracts into one of 6 categories, which shall be professional services, physician services. All contracts must be in writing. Furthermore, it is the responsibility of the respective department head to ensure effective management of all contracts pertaining to relevant to their department and contracted services. The final signed contract shall be forwarded to the hospital material management administrator for procurement contracts, to the HR office, and or the medical staff for personnel contracts, who will prepare the transmittal to and accompany the draft contract for review and clearance and signature by A, the Attorney General's office, as to form and compliance with local laws, B, Governor's office, final approval authority, signature required for the contract to be valid, enforceable. And they were also told, monitor the status of the contracts forwarded to the AG and the Governor's office. These policies were adopted just within the last several years, 2018 and again in 2021. There is no exception for physicians. In fact, in both of them, it includes medical and physician services. Yet, the administration of the hospital currently is of the opinion that because of the need to hire doctors, they have a different practice, which does not include sending it down to the Governor's office. And I know that everybody was confused with all the numbers that were put into the audit. But what we were trying to show was with the contracts that we reviewed, we didn't find signatures for the Governor's office. There were times when we didn't even find the same signatures on all the contracts. And that's why our recommendation was that there should be a specific, though there was this policy that they should have all complied with, and they were not complying with it, and if they were going to be writing, as they were saying, they were crafting a new policy, that new policy should include specific instructions on how PSAs, how UEAs, and how classified are to be dealt with, because their inability to follow this general policy necessitated that. But there is a policy, and until there is a new written policy adopted by a board, they cannot just continue to operate without complying with the rules as is stated. we've asked them for a copy of any rule, anything that shows that they have this, that shows the policy, the practice that they're implementing has been adopted by a board, has even been memorialized somewhere. They have not been able to provide that to us. So I said, issue this report. The management's got to know that there's non-compliance with a board policy from 21 and 2018, and that the board needs to do something to rein this back in. And with the amount of money that's being requested, maybe it should be required that the contracts that are costing tens of millions of dollars a year have to go down and be cleared by BBMR and signed by the governor, since you're being asked to appropriate an additional $54 million. But they believe that there is such a need to hire the doctors that they can't follow that procedure that is written. It wasn't adopted in 1996 or 1980 when they were established. It was not even 5 years ago. And so our conclusion was that GMHA lacks a general and specific internal policy to govern the contracting, hiring, and documentation process of physicians. The audit findings relative to deficiencies of GMHA's current and prevailing procedural processes embodies potential risk due to the absence of well-defined internal policies and guidelines in contracting for independent physicians, hiring of GG1 physicians, and insufficient, and we found that the files were insufficient and deficient with documentation. It is imperative that GMHA ensure effectiveness and efficiency in its hiring, contracting, and documentation process through the formulation of a well-defined internal policy and regulation and strict adherence thereto. Our recommendation, GMHA management emphasizes the significance of formulating a well-defined internal policy and procedure and guidelines and strict adherence and compliance to contractual requirements, effective review of contracts, and other pertinent documents to maximize and efficiently use the hospital's scarce resources. We believe that GMH's mission to serve the medical needs of the people of Guam should be supported by the government of Guam and its stakeholders. We recognize the efforts exerted by GMHA's management and staff to administer the hospital with a combined and wholehearted dedication of its physicians and all medical personnel who are committed to address the healthcare needs of Guam. We are available to answer questions and provide further clarification. Thank you.
Thank you, Public Auditor. GMH, did you want to respond to anything that the Public Auditor presented? First, I'd like to, on the record, where is Lillian Posadas? Why is she not here?
If I may, Madam Speaker, Ms. Posadas had an injury, and so she's not able to come today. We do apologize, but we communicated with her and explained to her that we would speak on her behalf. She's actually written a testimony that I'm going to read if you allow me to.
Okay, that's fine.
My name is Quasi. Please let me introduce my team. To my right, Ms. Hechinova, the hospital CFO. This is Mr. Pauloon. He's a hospital's lawyer. And then we have Mr. Rado, the Assistant Deputy of Operations. And in the back is the acting CEO, Mr. Tugade. Again,
I just had a question. Why isn't Mr. Tugade speaking if he's the acting CEO?
Mr. Tugade is the acting CEO, but because these issues require physician compensation, being the chief medical officer, I'm usually the one that discusses with doctors to go over contracts. And so for that reason, I thought I could address your questions in a more succinct manner, if that's okay.
You can proceed.
Thank you so much. Buenos and half a day, Madam Speaker, esteemed members of the Guam Legislature. It's with deep humility that we at GMH address the 30th Guam Legislature We thank this esteemed body for allowing us to address the people of Guam who we serve. This is a letter prepared by Ms. Posadas. Guahasi Lillian Perez Posadas, GMHA Hospital Administrator.
Please speak closer to the microphone so we can all hear you.
Yes, ma'am. On behalf of the Board of Trustees, management, medical staff, employees, and patients we serve, we appreciate the opportunity to discuss and present detailed findings, briefings, clarification, and explanations regarding the specific topics. Number one, Guam OPA Performance Audit Report Number 25, Guam Memorial Hospital Authority Contracted Physician Compensation Package and Privileges. Part 1, Contracted and GG1 Physicians. Hiring practices, technology upgrades, electronic health records systems, billings and collections, / accounts receivables, federal grants, capital improvement projects, current detailed staffing pattern. As I said in the opening remarks, we're here to engage with this leadership in a constructive, healthy, and solutions-driven strategic thinking dialogue. During this time, I'd like to turn it over to different members of the GMH team to briefly address the topics of the agenda today before we begin questioning. To my right is Ms. Gerardo, who will talk about the current detailed staffing pattern. I'm sorry, I apologize. To my right is Ms. Sheshinova, who will discuss the current detailed staffing pattern.
So this is this, can we pull up the slide? Yeah. This is just a summary of the current detailed staffing. So the total number of employees right now is 1,269. Classified employees comprise 89% of that amount at 1,128. Contractual employees is 6% at 72, and unclassified employees are 5% of the total at 69. Next slide, please.
So the details, so before I move on to the capital improvement projects.
Please speak into the microphone so we can hear you.
Before I move on to the CIPs, just to note that the current staffing pattern was provided to the legislature. So moving on to the capital improvement projects. So we're tracking a total of 57 projects, and as you can see, they're on the bottom left, the project status based on the number of projects, 50% or 27 of the projects we've already completed, and the remaining 27 is ongoing. Next slide, please. On the next slide, you'll see the 27 projects that have been completed. The last time we were here, I mentioned that we had completed, I believe, 17 at the time, so we're now up to 27. And so the more recent ones pertain to the refurbishment of the biohazardous waste autoclave. We received the paint and other supplies that our FM team used to prepare our rooftop for the solar panel placement. We received BiPAP machines, the ER suture room procedure table, glide scope, neuroplating system, our 40 kVA UPS device, that's the power source. For our IT, we received a total of 20 stretchers and a modular table. Next slide, please. So the next slide is our ongoing projects, which includes the automated medication dispensing system, or PICSYS, the 450-ton chillers and the 265-ton chiller, as well as the replacement of our air handling units, the replacement of the SNF HVAC chilled water lines, and so on. Next slide, please. Moving on to our federal grants. So on the table, you'll see there are a number of federal grants. The first one is the TAP Guam 2020-9. This is the GMH training program for nurses and the revenue cycle management staff. This grant is now closed. The expiration was last year, 9/30/2024. The following one is the TAP Guam 2024-5. This is training for the emergency nursing pediatric course. The training is going to begin on April 1, 2025 for our nurses. For the Guam CIP-2020-1, this is $3.5 million for GMHA's HVAC project. So this is hospital-wide HVAC, and that is currently ongoing. We have the Guam CIP 2019-2. This is for the Angio Suite and related projects. This was a total of $2.5 million. That project is now closed. We also received the DCIP, that is the Defense Community Infrastructure Program. This $2.7 million is to fund the Urgent Care HVAC Upgrade Project. We also have the HPP, which is the Hospital Preparedness Program grant. This is for our Guam Emergency Management Healthcare Coalition. This grant funds training, currently 2 staff, and then equipment and supplies related to emergency management and the Healthcare Coalition. And then finally, the National Library of Medicine. This is a recent grant related to the translation of the GMH's forms and other documents from English to Chuukese. So this is a current program, and it is the training is ongoing for 4 participants. Next slide, please.
For our billings, I have a comparison from 2023, 2024, and 2025 as of March 16. So in 2024, we really made a lot of improvements. That was really our catch-up year from 2023, when we had a lot of issues with the system going down. We had the typhoon. We did lose a lot of billing days in that year. In 2024, we were able to get caught up, and in 2025, we're now levelizing. So our monthly average billing now is about $25 million, which is what we expect. In 2024, it was above average because, like I explained, we were recovering from the issues from 2023. In 2023, our monthly billing was about 19.4, which is actually quite low. Next slide, please. For collections, also in FY 2023, our monthly collections were $9 million. We did get about $22 million in Medicaid advances to help us get through the fiscal year because of the lack of billing days that we had. So that is also counted in our average monthly collections. In FY 24, it was 9.9. This included a combination of some Medicaid advances, but it also includes the amounts that we were paying back. So DOA, when they compensate us for the Medicaid claims, they withheld about 50% of the reimbursement to recoup the amounts that we had in Medicaid advances. So as of this month, we are all paid off with the Medicaid advances. So we paid back $22 million that we borrowed in FY 2023. So we really expect, at least by this month or even April, for us to be able to keep all of the Medicaid claims that we receive, and that will greatly improve our cash flow. Next slide, please.
Regarding the technology upgrades, specifically for the electronic health records, I know that this question has come up many moons over, but what we wanted to share is that we do currently have a draft RFP for the new EHR system. However, in order for us to issue that RFP, we need funding. Per the assessment with our IT team, the amount for a new EHR, and that's also included in our 5-year CIP plan, is we're looking at about $60 million over a 5-year period. The initial startup cost that we're looking at is about $12.5 million for an EHR. But again, we don't have funding for that. What we're currently trying to do, and this is where the arrow is on your slide, we're currently trying to conduct an IT risk assessment and infrastructure assessment to help us, before we go into the actual procurement, we want to make sure we're procuring the right thing. Not only for the EHR, because before we even get there, we need to upgrade our infrastructure. As Sabrina mentioned, Senator Matanane mentioned earlier, my apologies, you know, there was an issue that we had recently that was caused by a power glitch, and it really exposed the vulnerability of our system. And, you know, so before we can even procure anything, we want to make sure that we conduct this IT risk assessment. And again, this, we just kind of lay out. We just lay out here, these are the other steps that we would need to take before we can issue an EHR. Next slide, please.
So back to the hiring practices, GMH has 2 different types of service, like most of the government of Guam, which is the classified and unclassified service. For our classified employees, we follow the current DOA personnel rules currently, but do have authority to draft our own. That has actually been a large project that our HR department has been consistently working on in the last couple years. And we also have some tools for the recruitment of nurses and other healthcare professionals that are embodied in the law, including 4 GCA Section 6229, that deal with classified merit system appointments for nurses and other healthcare providers in that service. So at this point, I'm going to turn it over to Rodolin Gerardo, who's going to talk about some of the issues and deficiencies that were present in the OPA's audit.
Next slide, please. So I will be going over just some of the issues that we found in the audit. And so particularly on Appendix 6, this is on page 107 of the Public Auditor's report. And on here, they took issue with contracted physicians without professional services agreements. However, one of the physicians that they included in here was a GG1 physician, and so should not even have been included as part of this table. Next slide, please. On Appendix 5, and I apologize, it looks small on this screen, but there is a line item here, which you'll see in the red box to the left. They combined 2 vendor numbers. The issue is not with them combining it, but if you look to the right, it shows the data that we actually provided to them. And here you'll see that vendor 203 and 265, you'll see data across from fiscal year 2020, 21, 22, and 23. However, when they combined it, you'll see that their fiscal year 22 and 23 shows 0. What this shows, though, is that it begs to question the accuracy of the report of OPA, simply from the standpoint that these are missing. Now, where it matters here is So this is Appendix 5, page 104. But that clearly affects the total on page 106, as well as page 7 in the report and throughout the audit itself. And so we just wanted to point that out for our senators. On the next page. Over here, this is Appendix 7. You'll find it at page 112 of the report. You'll see that the total earnings, for example, the very first line shows $342,725. However, that only accounts for the first fiscal year that they're noting, which is, if you look at the table, it shows fiscal year 2020, 21, 22, 23. So in this one, we clearly saw that, it was a formula error. It just was not caught. But we'd like to point that out. Next slide, please. So on here, to your left, is from the Government Auditing Standards Yellow Book. And this explains 4 kinds of evidence: physical, documentary, testimonial, and analytical. We recently attended a training actually with the AGA Government Guam Professional Development Conference, and in that training, I attended an auditing session, and again, the 4 types of evidence was confirmed: testimonial, documentary, analytical, physical. The order in which this was presented, testimonial and documentary, are the weakest form of evidence. And typically, as an auditor, when you have testimonial or documentary evidence, you need to have corroborating evidence to confirm facts. Now, analytical and physical would be the stronger forms of evidence. Physical being the strongest, related to the auditor's direct inspection or observation of the people, property, or events. Now, we take issue on this because we pointed this out to the public auditor during the, as part of the management response. And in the OPA reply, they say, based on the objectives of phase 1 of the audit, our fieldwork was focused on physical documentary evidence. Yes, there's physical evidence, and yes, there's documentary evidence, but they're not one and the same. Next slide, please. So again, to your left, you'll see sections in the Government Auditing Standards. And here it talks about the elements of a finding. So in a traditional audit, you will see criteria, condition, cause, and effect. It may not necessarily be spelled out that way in the report, but when you read it, you'll be able to ascertain the criteria, the condition, the cause, and the effect. And further down on section 9.18 of Government Auditing Standards, it talks about how auditors should provide recommendations for corrective action if findings are significant within the context of the audit objectives. So I point that out because when you go to, again, a snippet from the management response and OPA reply in the report, you'll see that they responded with a training, I guess, that they attended that emphasizes on the structural variation of traditional audit findings, which are classical, traditional with the 4 elements, normative, which is the criteria, condition, and sometimes effect, and descriptive, condition or actual practice, actual performance. But what's troubling to me is the last line of this. Our audit findings are a combination of all these types. I don't think we really get to choose. It's more of the, if you're doing an audit and you decide that you're going to use classic, then you're going to stick to developing all 4 finding elements. Otherwise, you stick to normative or you do descriptive. I don't think you get to choose a combination of it or a hybrid. Next slide, please. So again, to the left are limitations of the audit. So part of the Yellow Book states that the auditor should document the departure from the generally accepted government auditing standards requirements and the impact on the audit and on the auditor's conclusions. It further talks about how auditors should describe the limitations or uncertainties regarding evidence in conjunction with the findings and conclusions, in addition to describing those limitations or uncertainties as part of the objective scope and methodology. So to your right is a snapshot of the methodology that's found on Appendix 1 of OPA's report. But they don't really talk about their limitations. And the reason why I bring that up is because earlier on, we mentioned that they focus on physical, what did they call it? Physical documentary evidence. If you go back 2 slides. So they talk about physical documentary evidence, which yes, GMH provided documentary evidence. The problem we have is that they didn't go to GMH, so they didn't physically observe, they didn't physically inspect, right? They got the documents because we sent it to them via email, but part of the auditor's role or part of the procedure normally would be that when you conduct field work, you would go to the entity, you would observe, look at different things, interview people, and so on. So it kind of begs the question, how did they come to certain conclusions? Yeah, sure, we can read things and come to conclusions, but normally, again, you have to corroborate the evidence. And, again, they have to corroborate the evidence with other things.
And to add on to a couple of the points here, one of the policies that they cite related to the Personnel Services Administrator contract processing, that's the process used for human resources. We have a separate dedicated office, the medical staff office, that handles our physician recruitment, hiring, peer review, privileges, the whole gambit of physician support. The hospital is really divided into 2 administrative structures, the one for general employees and the administration of the hospital. And it's also then separately governed for physicians on a medical staff arm where they elect their own medical staff leader and all of these other things. And so what the OPA missed in relying on the contract for human resources is that applies to the rest of the hospital, but physicians have largely been governed as unclassified appointments and we've used a historical hiring practice for them. What that is, though, is with that policy that was relied on, it was cited in the final draft report without ever questioning or coming and speaking with the medical staff office that actually deals with and addresses these issues. So there was a lot that was just missed in making assumptions prior to actually communicating with, observing, and speaking with the medical staff office about these issues.
If I may add, here in Guam, there is a shortage of physicians and doctors. And as you know, we have 3 hospitals. There is Navy Hospital, there's GRMC, and then there's GMH. We're literally competing for the same resources, i.e., especially doctors. We have some doctors that work at all 3 hospitals. Some doctors work at both hospitals, GRMC and GMH. Take me, for example. When I first came to Guam, I was employed by GRMC. Within about a year or 2, there was a lack of neurosurgeons for GMH, and so I was tasked with working at GRMC and GMH. That was very challenging, but that was the need, and so I met the need. Currently, as it stands, Saipan doesn't have a neurosurgeon, so I also work in Saipan as well, in addition to working at GMH. Ideally, having enough physicians for the island would serve the people best. But because we are so isolated and because it is so hard to get physicians to come to Guam, we sometimes have to serve dual roles. I think one of the concerns for this audit was that doctors were performing multiple roles and then getting paid multiple salaries, which is not the case. Not all doctors are performing two or dual roles, but the ones that are performing the dual roles are using their time outside of their compensated work to do this dual role. So for example, I myself, I'm the hospital's chief medical officer. I'm also a contracted neurosurgeon. My company provides neurosurgery services to GMH. I have dedicated time that I perform my chief medical officer duties. I have dedicated time that I perform my neurosurgery duties. Now, because I'm on call for the hospital as a neurosurgeon, my job as a neurosurgeon precedes or takes priority over the CMO duties. And so, for example, if I get called right now to the hospital, I have to leave. And that is the nature of the work here. Another option would be to hire physicians that are not also working in the administrative duties, but then that creates the problem of having multiple expense as far as multiple staff. If you can have one physician that can perform duties of administrative and their medical duties, I think that would be a cost savings for the hospital. And I think that would also be appropriate because that physician knows medical care. Trying to hire a non-medical practitioner to run some of the leadership roles for medical is a bad idea. Within CMS, there is something called conditions of participation, meaning that because we take federal dollars, CMS mandates us to have certain roles in the hospital fulfilled. For example, the director of nephrology must be a nephrologist. You can't have a non-nephrologist be a director. Now, I can't ask my nephrology director to do the job and not compensate them. And so for that reason, we compensate them for their services as a nephrology director. Another example is CMS mandates us that we have a director of respiratory who's also a doctor. And so for that reason, these are the reasons why we have physicians in these roles as the directorships, because we're mandated by the CMS, who gives us our federal dollars when we basically provide care for these patients. As far as hiring practices for physicians, yes, there are three main avenues. There is the GG1, or the employed model, where doctors are employed by the hospital. Doctors get benefits. The doctors also get a W-2 at the end of the year when they're done. And then there's the independent contractor, where the doctors do not get benefits. And so if they don't work, they don't get paid. I myself, I'm an independent contractor for neurosurgery. But because I am employed by GMH as the medical director, I'm a GG1 or an employed physician for just administrative work. There's also a third avenue where we have an MOA, or memorandum of agreement. Sometimes it's hard to actually hire doctors, i.e. independent contractor or GG1, and so we use locums companies or what we call headhunters to find doctors for us. And we use this MOA in order to address that aspect of it. That essentially, I guess, defines how doctors are compensated. But to the point of, working and getting compensated, we have doctors that are doing work that they're not being compensated for. For example, the general surgeon at GMH, he does pediatric general surgery, he does adult general surgery, he does vascular general surgery, and he's not getting compensated more for that. Whereas in the States, all of these roles have individual compensation packages with them. I myself, I do adult neurosurgery, I do pediatric neurosurgery, I do vascular neurosurgery. In the States, that's 3 different people. But here in Guam, it's the same person that's doing all of these things. But yet I'm not getting compensated for each individual role that I'm doing. So the argument that doctors get paid too much in Guam is not realistic. we follow the MGMA guidelines for compensating physicians, which is a standard way that doctors are compensated in the States. All our physicians on Guam fall within the MGMA standards. No one is above it. And so this further shows that that is not the situation or the case. If you look at the percent of our budget spent on doctors' salaries, it falls within the industry standards and the standard of care. And so for that reason, I know we're not paying our doctors too much. If anything, we really should pay doctors more because of the work we do here. I think the Madam Speaker mentioned issues with hospital supplies and shortages. Yes, we have shortages in the hospital. Sometimes I have to go call Navy to borrow supplies. Sometimes you have to call GMHA to borrow supplies. But guess what? They also borrow supplies from us as well. They call us for supplies. This is not a problem with GMHA alone. This is a problem with the fact that we are a remote island and trying to get supplies is difficult. Sometimes we have an increased number of patients and we run out of supplies. And we do our best to get supplies as needed. Are we perfect? No. But I think that we are trying. Looking at the data that we presented, we've actually improved in our billing and collections. I think this should speak volume that we as a hospital and the administration is trying to do the best people of Guam. Thank you very much.
Thank you for all the work you do here on Guam and in Saipan. Yuka, you worked at the OPA, is that correct? Do you agree that this audit is flawed?
When we first got the draft, there were a lot of errors. We corrected them and sent them back to the OPA. They misclassified a lot of the doctors. The numbers were not adding up right. So that was immediately a red flag to me that we need to keep an eye on the audit. But after everything Rodolin said with the standards and all of that, I come from audit. I love audits. There's a joke. The auditor comes in and then the typical thing is, oh, we're here to help you, and everybody laughs and they're like, yeah, right, you are. I truly believe that auditors are there to help the agency, but there is a collaboration that really needs to happen. And one thing I was disappointed with in the audit is they never came to talk to us. They did not observe any of our processes. Everything was done through email, which is, it's easily misconstrued. If I type a sentence responding to something, you're going to misunderstand it. And one of the examples of that in the report was something they refer to as a fee schedule. And so they have a finding in here about a fee schedule that we don't have. And I said, yes, we do have a fee schedule. It's posted on our website. We're required by CMS to post our fee schedule. A fee schedule is a list of charge codes, CPT codes, and the procedure or the supply and the charge, the price that we charge for it. That's a fee schedule. And so we explained that in our written response to them, that you're misunderstanding what a fee schedule is. And so when the final report came out, the recommendation about this fee schedule is still there, but in my mind, it should have been gone away. We probably could have been, maybe that finding wouldn't have been there if they came and talked to us. And we did invite them a number of times to come and observe. You can sit with our medical staff, talk to Brenda, and ask her, so here's a doctor, how do you get him on a contract? How do you find the doctor? How do you onboard him? All these questions that you can ask directly to the people that are responsible for this process. Then you can make the conclusion on what policy you use. Well, we're still working on our policy. What about this policy, 8560? Yes, this is a policy, but right now it's not applicable. It needs to be corrected. And that could have easily been hashed out had they come and talk to us face to face, come and observe. We don't have anything to hide, honestly. Then I think we would have had a really good constructive audit. Maybe it would, I like audits because I feel like they're gonna save us money. That's the thing I'm thinking about. In the case of the hospital, how do we save money, but we have to always keep patient safety first and foremost? What Dr. Nayami said about how critical the doctors are, we are not a hospital without our doctors and our nurses. We have just survived a pandemic which has just upsided the entire healthcare industry. And we kept thinking we were just going to go back to normal after it, and we have not. Doctors and nurses are quitting the profession. They don't want to do this anymore because they're so burnt out from everything that happened in the pandemic, and now we have to pay a premium for a lot of their services. So I really just expected a lot more from the audit. I wanted to read it and it to be clear, to tell us what we need to do constructively to improve. And instead, it kind of went all over the place. I had somebody from audit background read it before, and they kept saying, I'm very confused, I'm very confused. And when you have confusion, then nobody's going to understand the audit. And the bottom line, or at the end of the day, you want your recommendations to be implemented because they should be addressing the root cause. What is really the problem? And tell us how we should fix it. And get the buy-in from the auditee so that at the end of, you're not waiting 5 months, 6 months to close a recommendation. We're just as excited about getting the recommendation implemented as you are. So it really is to work together. So that's what I just found disappointing in the audit.
Thanks, Yuka. BJ, Vince, would you like to respond to GMH's concerns about the lack of communication, lack of working together, this audit being flawed?
We tried several times to meet, and I think they'll admit that I get really upset when audits have a birthday. They should be finished within several months, but it shouldn't go past the year. But when we were trying to schedule exit conferences, we couldn't because people were traveling, people were unavailable. And so I said, release the audit because you've satisfied the finding. Are they complying with the statute? There was just an admission, 8650 has to be amended. It hasn't been. They haven't once addressed the fact that there are policies that say all contracts, and nowhere in it does it say except for physicians. Where is that? Even if we sat with anybody in the medical office, where is the policy? Something has to be in writing. It's not just, yeah, this is the way that we're doing it right now. Because when there is a written policy, then comply with it until and unless and until such time as you write a new policy for the specific, just for the doctors. We recommend that. That's our first finding. A specific and finding for the doctors, but put it in writing so that you don't have to go to, if the Lillian is out or if anybody's out, whoever's in charge will know what the process is. And I'm sure, I agree that doctors are necessary, but are they so necessary that they don't have to go to the governor's office for signature? Clear with BBMR and the AG? Where is that written that says that they can? It's not there. I presented to you the entire enabling statute and the two policies of 18 and 20, and 2018 and 2021. They're not complying with it. That's all we're saying. Yes, we may have had addition errors and computational errors and some of it. That's going to be addressed in the part two. This one was just pointing out, are you in compliance with something that's in writing? And what we have in writing that says all should include the doctors unless there's an exemption. They've not presented that to us, so the doctors should be included. If they're not, then where is it?
The problem is we have addressed these things. The policy related to personnel contracting, that 8,000 policy, We've addressed it. It says all contracts, but the area of responsibility there is human resources. Human resources does not have responsibility over medical staff. You have to read these policies in context. And so this is part of the struggle that we've had with the OPA this entire time, including their lack of visits to our medical staff office and observations and conversations there. There were public statements made by the public auditor before this even began about what he thought he was going to find. We never actually had like a neutral, fair shake at this. He was making public statements, I believe, at the Chamber of Commerce or some other public meeting, talking about the whistleblower complaints and what he thought he might find. And so all he did was, when we presented him with all of our justifications and all of the counter arguments and all of these things, still came to the self-affirming conclusion that supported his first statements that were made publicly, that he thought that there was some problem here. We follow the law, and we follow the law on these things. We have extensively researched the hiring practices. We've looked through the historical practices of hiring physicians at the hospital, and we consult with the other stakeholders throughout the government as to the hiring for it. And so the idea that we haven't addressed these things, we extensively addressed them. The problem was the OPA just didn't ever like to hear our answers.
If I may add as well, there is a hierarchy of criteria. So typically in an audit, one of the first things that the auditors will do is review what is the criteria. What is the baseline, right? So first thing they'll look at is the law. If there's nothing in law, then they'll look at policies. But even with the policies, and if the policies are not clear, they look at practice. Because before they can actually do any kind of test, they need to solidify their criteria. You cannot then turn around after the fact, when the testing is done, to now say, okay, we're gonna test you, or we tested you against this thing, when you never even solidified that with anybody. So, meaning to say, when they first came, or when the audit first started, and they were asking questions, trying to determine what is the law, what is the policy, and all of that, they never once confirmed with us the 8,000 policy. It was only in their draft report that came out. So it's like, where is this coming from? Again, that's not typical audit practice.
If I may, in addition to comments made by Mr. Benjamin Cruz, even after the audit was published, there is media report of him disparaging physicians. I can't say the word he used because I don't want to disrespect the senators, but I find it troubling when we as physicians are working hard, but the leaders that we elect are making very disparaging and careless statements that is not true. I think it was something to the effect of, we're so busy doing admin work, we can't see patients. GMHA does not turn patients away. We see all patients. So that really makes me concerned that we're losing the trust of the people in Guam. And as a physician, that is the one thing that we need in order to make the patients feel better. So that makes me a little bit concerned that elected leaders are making comments that are not true. As far as any written policy for hiring doctors, I will admit there is no written policy that I can read as a chief medical officer that tells me how to hire doctors. What is there is historical knowledge and data, which has been going on for a very long time. I myself am new to this role of chief medical officer. I've only been here 6 months in this role. In that time frame, I've learned quite a bit. But what I did was, the first 2 months, I spent time observing the prior chief medical officer, and in discussing with him and discussing with Ms. Mendesano, who's the medical staff coordinator, I've learned how doctors are hired, and I've learned the knowledge to be able to do that. We are currently in the process of codifying that in a written policy. That way it can be followed. So I agree with the OPA. We do need to have written things. I agree that I'm not disagreeing with that. I take responsibility for that. But for comments to be made to say that we are not doing, our job and that we're not taking care of people, I think that is false and that needs to be corrected. Thank you.
If I may add one more, I'm so sorry. But, just doing the math, right? If you take the $105.9 million that is stated in the OPA report, divide that by 4 years, which is the 4 fiscal years they're looking at, and divide that by the 168 physicians in the report, you'll come up with a number, and the number is 157,589. So that would be the average number or average pay that the physician is making if you look at it from that standpoint.
How long have you been the chief medical officer? You said
6 months.
6 months?
Yes, ma'am.
And what were you a chief medical officer at another hospital before, or what qualifications do you have?
I have. I started a degree in public health policy during my medical school training. I didn't finish it, but I took a semester and a half. So that's my training for the chief medical officer. I was also the quality officer at GRMC. I was also the nursing educator at my previous job. That is a qualification that I have for my current job now. I'm currently taking a course in Chief Executive Management through Emory. It's an online course that I'm taking. And so I'm taking the initiative to educate myself on how to do this job. One of the concerns that I had was that prior to me taking the job as CMO, in 2018, there was a CMO, Dr. Bordalio, followed by Dr. Uggan, followed by Dr. Duenas, Dr. Lizama, Dr. Prince, Dr. Seidel, and then myself. In that short time frame, there's been multiple CMOs. That made me concerned that this job may be something that is too difficult for me to do. I've confirmed that notion. It is a very difficult job. This is one of the most difficult jobs that I've had, and I'm a neurosurgeon. And that's because healthcare is very complicated. It's complex. It's the intersection between IT, between business administration, between medical care, between insurance companies, between government regulations. You have to understand multiple facets of it. But this is not an excuse for us not to do the job. Because we don't understand, we have to educate ourselves, and that's what I'm doing. So I understand why the audit has errors. Healthcare is very complicated. There's no wonder why there's errors in this audit. I don't think any one person can understand all of healthcare. But yes, I've been in this job for 6 months, and that's my qualifications. I'm trying to learn more, but trying to find people to do this job is not the easiest.
So you're just learning on the job. You have no experience as a CMO. Is that correct?
This was my first job as a CMO.
And so you get paid as a CMO, a GG1 employee?
I get paid as an independent contractor providing neurosurgery services to the hospital, and I get paid $170,000 per year as the chief medical officer.
And then you work in Saipan as well?
I work in Saipan 1 day out of the month, 2 days out of the month on Saturdays.
Okay, thank you. And you get paid for your company?
I don't get paid when I leave Guam. So if I leave Guam, I don't get paid for working here in Guam. In Saipan, I get paid about $3,000 a day for working in Saipan. I pay my flight, I pay my hotel, and I see patients there. I do surgeries there as well.
And you also get paid while you're on call? That's a separate?
No. So my contract with GMH is that I provide neurosurgery care for 24 hours while I'm on Guam. So I get one pay for 24 hours, period. So from 12 a.m. until 12 midnight, I get one pay for that.
Okay. BJ or public auditor, anyone from the public auditor wanted to respond to anything that was said previously?
Yes, and I apologize to the doctors. What I should have done was I should have had prepared statement like I did to you guys here, when I was doing the interview for KUAM, because I spent the first part of it explaining to the interviewer the fact that the criteria was the law. The law says the Board of Trustees makes the policy for the employment of everybody at the hospital. And then I pointed out to the interviewer the two other policy that had been adopted by the board in the last 8 years. Unfortunately, I was goaded into making a comment, and my entire statement about what I presented today was lost, and I apologize for that. I should have learned that just stick. And that's why I'm saying the criteria is here. Mm-hmm. The law says the board does the policy, not someone trying to figure out what it was, what the historical practice was. If they change as many CMOs as they've had, the CMO should know that this is the policy for UEAs. This is the way you deal with PSAs. This is the way you deal with classified. They don't have that in writing. And all we're saying is get it in writing. And until you do that, follow what was adopted by the board, which was supposed to be doing this since the implementation of the hospital, or explain to me or my auditors what all doesn't mean. Why doesn't that include doctors? There's no exception in any of it. In fact, in 2610, it has the physicians. It has to be in writing. That's all we're asking. That's all this audit is, the first one. Yes, we included lots of numbers, and maybe there might have been computational areas. Fine. But there is no error in the fact that we say that the criteria is the law and the policy, not the practice yet, because we found written policy and the law. And it's not being complied with, and they've admitted, almost every one of them has said that it's not been, that they're drafting something, but it's not been adopted. That's all we're asking. Adopt something. Since the beginning of this audit, they could have adopted something and mooted the entire thing. We would have moved to part 2.
Thank you, BJ. I kind of wanted to bring this back to why we are here and why this audit was conducted. It was because of, as BJ, you said earlier, whistleblowers and people coming forward. And I'm going to go to one such whistleblower who is on the line via Zoom, who'd like to share with us his perspective on this audit. Dr. Shea?
Yes.
You have about 5 minutes. Thank you for joining us.
Yeah, sure. Thank you very much, Senator Sabrina. 5 minutes is not too much time, but I'll be open for questions. But just a couple of comments that I've heard so far. First of all, I want to commend the public auditor for taking the initiative to do the audit, and it's long overdue. Now, the point that someone said, the medical staff has their own things that they do that they're from the admin. Medical staff is supposed to be independently governed. Independent means self-governing medical staff, essential, right? That's what it says, to maintain the physician autonomy. But that's not what it is at GMH. The administration runs the medical staff. They tell Brenda what to do. They instruct the medical staff what to do and to what extent. And that's exactly what's going on at GMH, okay? So GMH, the term that's always somebody says, GMH sees all patients. I mean, who are they trying to fool? GRMC also sees all patients. Every hospital are conformity to the what you call EMTALA law that sees all patients. So it's not just GMH. And the job of the medical director was never quote unquote searched. In a reputable hospital across the country, there's always a search for the chief medical director. In fact, Lillian's position, the CEO of the hospital, is always be a national search. And the reason it is because of qualifications. Usually, even the chief medical director needs what we call MBA in hospital administration. And I'm glad Dr. Niami is there, and I know him very well over the years. And he's asked me for some advice. And, truthfully, his hand is tied too, because he has to listen to whatever the administration tells him to do. And that's a fact. That's a fact. But there's one more person that says, well, if you take the 3 or 4 years out of the audit, if you average out the physician salary to be only 100-something thousand per 100-something physicians, that's not the way to categorize that. That's totally foolish to be looking at it that way. What you need to do is dig deeper, and I'm going to show you something here. I think there's a great disparity in contracting of provider contracts at GMH. And, I brought up this concern before, and, bless Niami's heart, because he can't do anything about it because he's controlled by the administration. Now, if you can put up just 3 slides, I have 3 slides to show, and I'll just pick this up because I only got 5 minutes, and I'm open to questions. So if you can show the first slide, and I can go over that. Okay, so everybody can see that one slide? Can you still hear me?
We can hear you.
Okay, the slide basically shows that, let's just take one example of OBGYN. I'm a board-certified OBGYN. This one particular contract pays this particular OBGYN $4,800 per day, plus $1,800 in bonus. I brought this up to the administration several times, and the only reason I brought it up is during a call, they wanted me to take call, and they say, well, then you got to have parity. You can't have disparity in contracting. What, the former judge and Senator B.J. Cruz, which is the OPA, now said, there's no policy. There's no policy on contracting, period, which I think there should be. It's got to be parity across the board. If you can pay one OBGYN $4,800 per day, which is quite a lot, and that's apparently more than what Dr. Niami gets paid in Saipan with $3,000 a day, plus they're seeing patients, etc., in clinic, and plus $1,800 bonus. There's no other OBGYN that has that particular contract at GMH. When I asked why that's the case, they couldn't give me a firm answer. So I did a FOIA request, and, the FOIA request actually was very specific. And within the email communication between Audit and Public Health, this one particular physician actually took a picture with Audit sending a press release that says, we hire an OBGYN for public health. When you come down to it, when I look at the very detailed specifics, there is no MOU that was signed by Public Health and GMH. So how did this contract come about? Was it because of direction from the governor down to and provide a special sweetheart deal for this particular physician? It's not the physician's fault. I want to make that clear. It's the administration's fault that to allow this to happen. Okay, and this is where the disparity comes about. Now, I'm still asking for the MOU from the email, and that's refused. I asked Brenda, who was on that email chain, and I have all the documents. If the senators want it, I'll release them. It's open to the media too. They should get these, because when you work with the government, they have to be transparent, and they're not being transparent because that MOU has never been released to me. And when the governor is saying, well, we forwarded the Attorney General's office, he never provided this, they themselves are doing it. They're not providing all the information that's in the FOIA request. Let's take the next slide, for example. This next slide here is actually a contract for a pediatrician, but the provider in this particular contract is paid $3,600 per call per day. And she's a family practice, not a pediatrician, a family practice. So I called another pediatrician and said, how much are you getting paid at the hospital? And he said, well, I take pediatric call, newborn call, and he gets paid $2,400 per day for the same type of work. But you can see that this contract is $3,600 per day compared to a real pediatrician who's gone through 3 full years of pediatric training and is getting paid $1,200 less. How did this happen? I brought this up to Lillian. I think it was a year, 2 years ago. Still nothing is done. And you know what's worse? What's worse is this, okay? The person who is on pediatric call at the same time is taking call for their own clinic on government time.
Thank you, Dr. Shea. Did anybody have any questions for Dr. Shea? I'd like to open up, Dr. Quasi. I'd like to open up questions now to my colleagues, or for my colleagues, beginning with Senator Terlahi.
Situsmasi, Madam Chair. And thank you to the GMH representatives here. And there are several who have changed the management team over the last maybe 5-6 years. So I'm grateful for you who are doing the work. I read in the news recently that the Board of Trustees at their most recent meeting expressed this general sense of dread in appearing before the legislature because of their past experiences. I was surprised that they were concerned that having to come and appear before the legislature and answer questions. They seem perplexed at why the public is frustrated, maybe, or why senators would demand accountability. Some of them thought the team, your team, was not being treated well here at the legislature. But I have seen firsthand myself and other senators in the 35th, 36th, 37th legislatures try their hardest in good faith to make sense of the answers that GMH is giving us to things that were not making sense, to complaints that we were receiving. We tried our hardest despite some failures, outright errors, or short funding to find more money than the governor had put aside in all of her budgets for GMH, and to give that money that we found to GMH. And the whole nature of this oversight is to get answers that we have not been able to, or to make sense of things that do not make sense based on limited information that we have received. And so I thank the chair for this. But what I really find misplaced is this outrage of having to appear before an oversight hearing. When ultimately legislatures are trying to get answers so that we can help GMH, as we have done or tried to do over the years. Where was the outrage when the legislature in 2024 responded to a vendor crisis and shortage of supplies? The legislature passed a supplemental budget to give $30 million more to GMH for vendor payables because the governor said could not use ARP funds for vendor payables, but she promised to give $20 million ARP for CIP projects that GMH said were critical. That was in 2024, and GMH only 2 months ago discovered that the governor took back the $10 million of ARP funds for the new hospital, and DOA used the other $10 million for vendor payables instead of CIP projects. Those were the only funds that you had for capital improvement projects, including a new maternal child health ward and the new neonatal ICU and the chillers that have been an issue even before the Army Corps assessment 5 years ago. Where was the outrage when she took that money after all your work? Where was the outrage when we received $500 million in typhoon recovery funds, and the governor said she wants to take $400 million of that for the new hospital, while the current hospital still has no money for capital improvement projects that are critical? Whereas the outrage when the person was turned away when they needed admission to the hospital and died? And where was the outrage when the baby died? Or the outrage when Mr. Lebowski's child died? And all the other patients, as the Madam Chair has said, who have come to us and complained about issues there, that GMH response can be solved with these CIP projects, with this additional funding. Where was the outrage of the board when, in my very first term as health chair, we added $10 million to GMH's budget for capital improvement projects because GMH had requested none. The governor never gave GMH the money. And where was the outrage year after year since I've been a senator when the governor's budget and amounts set aside for GMH have always been less than what GMH comes in and requests or says that they need? And where was the outrage when GMH never received the $15 million for the maternal child health ward or the NICU appropriated since the 36th Guam legislature, and we're in the 38th. And where was the outrage when the governor's fiscal team came down recently on the first day of the FY25 budget session to suggest additional funds could be used? We could raise our revenues and we can give these to many other agencies, but they did not include GMH, despite what GMH said was a shortfall from their budget request by 36 million. And where was the outrage when it was GMH who shut down their computer system and let the nurses go manual, shut down the billings, and you were unable to meet your revenue projections that you projected? And where was the outrage when the former manager said the reason the CIP projects specifically for the maternal ward had not been done, although they were critical at least 5 years ago, was because he was told to concentrate on the new hospital? And where was the outrage when GMH management decided they needed a new EHR and spent $5 million to upgrade the current EHR, never bought the component that would link it to the billings, and then all of a sudden decided after years and millions of dollars that this EHR is not the system for a hospital and instead is for a behavioral health setting, and taxpayers need to spend at least $50 million more for a new EHR system? GMH told us in March 2024 that they were issuing an RFP for a new system, but we are here 1 year later. They say they don't have money, the $12 million needed for an assessment for a new system, let alone the $60 million for the actual new system. And then we have a consulting contract from GITA, not GMH. It was discovered in October 24 when we were here for a GMH oversight. GMH knew nothing about this consulting contract that GITA was issuing. So they're asking somebody, GITA's asking this consultant to tell them these things. And my question is, does GMH not already know the answers to these questions? An analysis of the healthcare needs of the population of Guam, including its subgroups and the region, and a projection of future healthcare needs. A description of the organizational, programmatic, and fiscal challenges being experienced by rural community hospitals across the United States. An analysis of regulatory and accreditation mandates that impact various organizational structures. An analysis of hospital revenue streams, especially this one. Hospital revenue streams and potential untapped revenue streams. I think it's going to be part of the contractor's work to go to GMH and ask you these questions, but I'm hoping you already know the answers to these questions. Otherwise, how are we managing? And maybe that's why we're seeming to go around in circles. A description of the skill sets required of leadership positions that would maximize the likelihood of success of a new hospital. I hope that assessment has been done for the current hospital. A description of the challenges of continuing need for government funding support or other strategy, continue medical care for patients who are unable to pay for medical care. Isn't this where the government subsidy comes in? That's what we're paying for. We are paying on top of the revenue that you are producing, we are subsidizing, the taxpayers are subsidizing GMH for patients who are unable to pay for medical care and to make sure that we have specific services that we need on Guam and are not being provided by any other providers. A recommended organizational structure that could further ensure the likelihood of a successful and sustainable hospital. So this contractor is going to be paid, I think, $50,000 in monthly installments of $10,000, and they're supposed to come up with a product within 90 days. But I don't know. I guess I just want to know. I mean, I wish the trustees were also here just to see in person and feel in person. I don't think anyone here is going after any one of you individually or personally. I don't think the auditor was doing that either. I just think we're all trying together to put everything we know on the table and make it make sense. And so I just want to thank the chairperson for having this hearing. And again, just to point out that some of these things have been on the table for very long and still not solved. Some of them are making progress, as you said, the buildings, and I'm very glad for that. But we heard in the last hearing again how our buildings are still short, right? Because of the payback amounts that we receive from insurance companies and Medicare, of course. So we still need to resolve many of those. So, Situs Masi, Madam Chair.
Thank you, Senator Terlahi. Senator Lujan.
Thank you, Madam Chair. And good morning. And Doctor, thank you very much for all that you do for Guam and the CNMI and all your services you provide, and all the doctors as well that provide the services for the people of Guam. Thank you very much for that. That being said, we have to do our job as well. And I hope you would appreciate that as well, to be held accountable to the people of Guam. So thank you very much. You know, earlier as the chair opened up the oversight here and talk about all the situations that not just recently, but over the years in regards to the challenges and the news that are making headlines, the deaths and things of that nature. I don't think any of the OPA's report had anything to do with those. Would you agree? Anyone for GMH? Okay. Thank you. That being said, Doc, we know that hospitals have standard of care, and acceptable, I guess, challenges and all that. Would you say that what was mentioned earlier by the chair is within the acceptable standard of care?
I would say GMH falls within standard of care in certain instances, and in certain instances we fall outside standard of care. I don't know if 5 minutes is enough for me to explain to you where it is, but I'm happy to talk to you outside of this and explain to you exactly what we can do better as a hospital, because you're right, we have to take responsibility for the hospital and the job we do.
And our goal here, again, is to have a safe standard of care, give the people of Guam the best that we can. And, you know, we keep doing this on a year-to-year basis. And when I served at 27th, 28th, 29th, I served with Auditor Cruz at the time, that's 29th, we pour money after money after money into the hospital. And whether they say, you know, keep doing the same things all the time and thinking you're going to get a different result. I was talking about earlier about $20 million that was infused into GMH. I know that was my bill that did that in the last legislature. And it seems that, you know, at the time, it seems that was going to be a fix. But here we are today, the next legislature, and we're a lot worse off today than we were back then. Let me ask this, because I had proposed this, and, you know, there was a talk also earlier about, of course, we don't want to hear anything about the new hospital. We need to take care of what's happening right now. Okay?
Yes, sir.
What would a 22,000 square foot facility, new facility, add to GMH at this point? What would that enhance its facility?
There's no secret that we have to fix our house first before we move it to another house, because then you just bring the same dirt and mess you have. So I agree with you.
So if you had 22,000 square feet of new space, that would be something that will probably take care of some critical needs of the hospital, right?
Well, it would take care of the fact that when the next typhoon comes to GMH, we may not make it. So a new facility will fix the physical structure, but the internal structure also needs to be fixed as well.
That being said, 44,000 square feet, would that be even better than the 22,000?
I think we have to look at the Guam's population needs as far as what we need and what we want to provide services-wise, and that will tell us what size we need to build.
Well, here's the thing, and the reason why I was asked this, because the last legislature, I toured a facility, the medical arts facility right in front of GRMC. You're familiar with that, okay? That facility is vacant at this point. I suggested that be an interim facility for maybe what's more critical with the GMH, what's more critical. It may be an interim. It could be a permanent thing with an outbuild as well with that, because that's the only facility at this point that is probably almost ready, or well designed almost for a hospital setting. I mean, we can't recommend a school to go there. I mean, so the closest thing we get to is be a hospital setting. Likewise, I remember GRMC at one point had a maternity ward. They no longer have a maternity ward. Can we work something out with GRMC to, again, maybe house the GMH's maternity ward there, and another more critical area within the 22,000 square feet, or even an additional, because I spoke to the owner, he said, it'll take me a year to build out, and you can have a facility. What would that do? I mean, you know, we have something that we can work on today. A year from now, we're talking about a new hospital that, you know, we're not even close to ribbon cutting at this point, or groundbreaking at this point. How about something that's almost ready within a year?
I think your points are valid. My understanding is that facility at GRMC was not built to be intended to be a hospital,
Sure.
more of an outpatient clinic.
Sure.
A hospital planning is very intricate. You have to have lines for gas, lines for oxygen, lines for electricity. You have to have different panels.
It is lined for oxygen.
It is.
Yes, yes.
To retrofit that facility to a hospital would cost more money than what it would take to build a hospital.
No. I'm saying, I know it's not going to house the hospital. I'm saying the more critical area that can be housed there. I'm not saying you're going to move that hospital there to, you know, at 22,000 or even 44,000 square foot. It's not going to suffice for all of GMH at this point. I'm saying the critical areas at this point, like your maternity ward, which was once they once had at GRMC. And I said the most critical area that you can house within that facility, and I'm told it can be built out within 1 year. Not a total hospital setting, but it's the closest that you can get in retrofitting a facility, an interim facility at this point. And we're needing something right now. I mean, it's falling apart. My understanding, because I oversee utilities as well. I understand the glitch that we had. We're knocked off the computers and all that. Wasn't on the GPA side. It was internal, inside of the hospital side. That's what I hear from GPA. But it's a facility that we need, a new facility. But we need something right now as well. And I'm just saying, what can we do in an interim?
I think we can explore moving parts of the hospital into that new facility, but to move the entire hospital, like pediatrics, internal medicine, surgery, OR, that's impossible. But parts of it, yes.
Sure,
like maternity,
and that's what I'm saying. I mean,
that's a good idea.
You are the professionals. I don't know what you can move there, what's more critical that you can move there within a year that it can substantiate, can help out, the more critical needs in the hospital. That's all I'm saying at this point, because that's the closest. I can't recommend the one that's over by JFK that was once looked at for a facility for a school, because it wasn't built for that. Right. This one, yes, for the clinic. So this is the closest that you get to a build that's close to a medical facility. That's all I'm saying, that we have to look at that, because again, we're not close to a new hospital, but what can we use as an interim, and not in totality, but maybe the most critical parts at this point.
I'm open to that. I'm happy to talk to you more about it, see how we can get things moving forward.
Thank you. Thank you very much. Doc, one other thing let me ask, because you talked about specialty areas and that you do surgeries, again, on, in the States, what you do here, maybe you're 3 different specialty doctors do that. Do those specialty doctors then need different certifications to do that while they're in the States?
That's correct. So a pediatric neurosurgeon, that's an additional year after 7 years of training. Okay. I'm an adult neurosurgeon. I've done all these 7 years of training. Okay. I don't have that certification, and so I only do emergency pediatric cases here because otherwise they're going to
Okay.
die. So once I stabilize them, I transfer them to the States to get the elective procedures by the pediatric neurosurgeon. So when I say that I do multiple procedures, I'm doing it as a life-saving measure.
Okay, okay. So it's, I mean, what someone would do somewhere else, 3 different specialties, we're doing here is one person or one doctor, not necessarily certified, but for life-saving measures, right?
Some people are certified, but for the most part, we're not what we call board certified. So I'm a
Certified,
board
okay.
certified neurosurgeon.
Okay.
I'm not a board certified pediatric neurosurgeon.
Sure.
But we have some board certified pediatric specialists that are also board certified in adults. But for the most part, we're adult board certified doctors doing pediatric care.
Okay, okay. Get the GMH, maybe the folks, in regards to the situation that, of course, the situations that the chair had pointed out. I mean, do we have answers as to, I mean, this has happened within the hospital facility. And, you know, when we look at the number of employees, as was told earlier, and then we have a patient that died in one of, I mean, within the hospital facility. How did that happen? How did that happen? And how did this patient get released and was in excruciating pain and I mean, you know, this patient must have been in excruciating pain as she was released and as she walked or wheelchaired somewhere else. I mean, I don't understand how that can happen.
Sorry, we understand the concerns, but it is an ongoing police investigation, and we're waiting for the reports of that as well. But also, federal law, which is HIPAA, which is the Health Insurance Portability Act, prohibits us from disclosing any information related to any specific cases. So unfortunately, we cannot answer specific questions about specific cases.
Even in a death investigation? Like that?
To the extent that any disclosure would reveal or potentially reveal any protected health information of an individual, we cannot disclose the information.
You know, just one last comment I want to make. I mean, this kind of reminds me, back in the 28th Guam legislature, we had, actually I was the vice chair, Dr. Mike Cruz was the chair of healthcare back then, and an audit report came out, and at that time, there was a pharmacist that was being paid 24 hours a day, 7 days a week. And at the time, we were challenged with, and none of you were there at the time. At the time, we were challenged with meds. When they were prescribed medicine, they would have to go, if Superdrug was open or Megadrug was open, they would have to go down there. But this individual was being paid 24 hours a day, 7 days a week, and that individual was also working part-time in one of the private pharmacies. So this is kind of reminiscent of back then, on an oversight hearing back then as well in regards to findings. So I just want to say, again, none of you were there at that time, but that was a finding at the time. But anyway, Madam Chair, thank you very much.
Thank you, Senator Lujan. Senator Gumatata?
Thank you, Madam Chair. And if you will indulge me, I know that Senator Barnes had stepped away, and she had asked if I could ask 2 questions for her. I know that we're looking at time, but if you allow me to ask her 2 questions, and then I can ask mine.
That's fine.
All right, thank you, Madam Chair. Thank you all for being with us today. This is from Senator Tina Barnes, and this is in relation to the collections slide that you shared earlier. What is the status of your billing on average this year? How many bills were not transmitted to or rejected by health insurance companies because they were not finalized in time?
I don't have that specific number. I can get it to you, but it's very minimal. We really do get the claims in on time. The only time we would not make a claim on time is for usually circumstances where the documentation was not complete and we're not able to code the claim. That's happened. But in other cases, we really do, what we're doing now is we're really monitoring that timeline. So if we have 90 days to get that claim into the private insurance company, and we notice it's still sitting on the unfiled, we will investigate at least a week before, hey, this claim is coming up to timely filing, and then we'll go see what's going on so we can push that claim through.
All right, thank you. And the second
I'm sorry,
question
if I
from
may.
Senator
The reason why documentation may not be complete is because some doctors don't complete documentation on time. And that's because there's a policy that gives us 30 days to make a report. Right now, we're trying to reduce that number to 10 days. That way we can get on top of doctors before the 30 days because it affects us sending bills out. So this is an example of something that is an internal flaw in the hospital that we're trying to fix to make it better.
Okay, thank you, Doc. Let me ask the second question for Senator Barnes. She says that she remembers GMH utilizing an amnesty-type program to help encourage residents with hospital debts to settle their accounts with you, GMH. How many people have taken advantage of that program, and how much revenue has it netted so far?
That program, I don't remember the exact number of patients that came in to take advantage of it, but we did collect over $600,000 in the 3 months that we had the program active.
All right, thank you. Madam Chair, I'm going to go ahead and ask my questions now if I could. Thank you. So again, thank you all for being with us. Can I ask GMH, and this is based on the audit, but can you provide the committee with an update on the formulation of a written policy for employment agreements for physicians as mentioned in the audit and earlier in this hearing by our public auditor?
So our medical staff is looking at that topic, and the first thing that they've been doing that was part of the audit as well is going through and writing down the processes as they are. Part of the challenge with getting a singular written policy is hiring physicians across various practice groups is not always quite the most uniform, simple thing that you can imagine. Various doctors require sometimes, different terms, different equipment, different things like that. So we're trying, so one of the things we've done first and recently is standardize some of the forms that we're using in contracting physicians, and then our medical staff office is actually going through to try and detail out their processes to see if we can even write an appropriate singular policy for the varied different things that happen in medical staff.
And this is coming from the audit, but do you not agree that a written policy would assist with ensuring the guidelines for appropriate use of the PSA, UEA, or MOA at the Guam Memorial Hospital?
Sometimes it can, but sometimes it can get in the way of contracting physicians, and so that's what we're actually trying to study, is whether we can formulate a singular policy that actually helps us hire physicians and streamlines it and helps reduce costs, or if it's just going to add to the administrative bureaucracy that increases the costs and delays the onboarding of physicians.
All right, thank you. The OPA audit noted that based on a sample of 20 personnel service agreements for physicians, the agreements did not bear the required approval signatures of the HR or by the HR Board of Trustees General Board, BBMR, Office of the Attorney General, and the Office of the Governor as the final approving authority. Under what legal authority were the agreements executed, and what liabilities are we exposed to as a government by allowing GMHA to continue employing anyone through a personnel service agreement that is technically invalid?
The personnel services agreements that we have are not technically invalid. The provisions about adding signatures are actually from portions of policies that apply to different forms of agreements or contracts as entered into the hospital. The Board of Trustees and the hospital administrator are the appointing authority for physicians who are appointed into the unclassified service. And anytime we hire somebody into the government of Guam, it doesn't require the governor to sign off on every single employment decision that's ever been made.
So Jordan, you don't think there isn't any liability whatsoever?
The liability will be confined to the actual services rendered that come out of GMH's budget in a year. But I think by even accepting the public auditor's numbers about how much we're spending on physicians every year comes out to about 10% of our 10 to 12% of the total GMHA budget in a year, and I believe that to be a little bit high, but even then, there are established processes. If somebody believes that they're not being paid appropriately, they can file government claims. They can try and resolve it informally. We typically don't have employment disputes with physicians and other employees when it comes to actual compensation, because one of the things we do prioritize is trying to pay our people. I know that sometimes you get the stories about the network being down and having potential delays and other things like that, but that is the first thing on our mind is trying to make sure that we make good on those obligations to the people that show up and give it the hard work, including our physicians, who are really, between the physicians and the nurses and other medical staff at the hospital, are really the lifeblood of that organization.
Now, in the event that a contracted physician also operates their own private clinic, what provisions are in place either through that physician's contract or GMHA standard operating procedures are there being, I guess, to ensure that there's no disruption in the provision of care if the physician is unavailable to GMH at any given time?
So most physician contracts require physicians to work a certain number of shifts per month. A lot of them require somewhere around, a full-time physician contract may require around 14 shifts per month, for example. There may be on-call shifts as part of that 14 or in addition to, where they won't be physically at the hospital, but if there's a surge in cases or if physician's out, they will be called in to handle particular cases and be paid according to that. We do try and take every measure that when you are under the contract of GMH, you shouldn't be, that needs to be your number one job, is attending to the patients there. I don't have personal information on the double availability, or however you want to call it, shifts. That is something I've been keeping an eye on since I've been there to try and reduce that. But I do have to say, we do sometimes in areas when there's a big crisis and other things, we do have a lot of cases and not enough physicians. So I can't promise you that nobody's ever been called in when there's other things happening island-wide, but we have been trying to make sure that all of our contracts prioritize that. And one of the things that we're working on, the other attorney, Rob Weinberg, and I have really been going through and reviewing all of the contracts, personnel contracts or agreements in the hospital, and trying to make sure that they do prioritize GMHA work consistent with the rules and regulations, even for non-physician staff that talk about, who are not under contract, that talk about outside employment and prior approvals for those things as well.
All right, thank you for your answer. What considerations have been made to extend physician contracts to include services at the Guam Behavioral Wellness Center and Department of Public Health and Social Services, and to require that these agencies to assist with costs?
So I can give one example, and then I'll let Dr. Naomi also fill in a little bit. There was one of the examples of an OBGYN contract that was joint, that had come up during Dr. Shea's testimony. That was actually a joint contract for services between providing services to public health and GMH. There were some issues in getting the ultimate public health clinic set up, but that was a joint partnership and effort. We have had some issues recently with the limited services in the community health clinics from public health, because it is a little bit hard to partner there, given the difference between the funding sources for public health that can rely a lot on federal dollars and grants that we don't have, and we also need to make sure that we're complying with CMS and other regulations like that, which are different between the organizations. We have been trying to work together. There is I know the governor and Lillian serves on this. There's a tri-agency meeting of the health agencies between Guam Memorial Hospital, Public Health, and Guam Behavioral Health that happens periodically as well, to see how we can offer those joint services. And we are exploring some of those options. It is just, given some of the federal regulations, poses really some real challenges for us in that way. Dr. Naomi?
So patients are sent to behavioral health as an outpatient. So if they come to GMH and they need behavioral services, they're not seen as an inpatient. I did reach out to the psychiatrist at Public Health personally and asked if there would be any interest in GMH hiring that person as an inpatient psychiatrist to help out with our psych patients. Unfortunately, he said that right now the amount of behavioral health patients in Guam is so large that he would not be able to have any time to do that. I've since reached out to psychiatrists in Saipan to see if I can do a telepsychiatrist program where they provide psychiatry through telehealth services, and so that's how I'm trying to bridge the gap and address the need. Thank you.
Madam Chair, I think when people talk about the doctors at GMHA, many times people will think of their hospitalists as, quote, or labeled as some of the highest paid in America today. I just wanted to share with you. And when we look at the U.S. Bureau of Labor Statistics, Occupational Employment and Wages, their May 2023 report, the mean annual wage is just around $48,640. And this, when they think of federal, state, local government hospitals. And when we look at some of these that were listed in the OPA report, a hospitalist internal medicine at $342,725, a hospitalist of general surgery, $377,166, a physician emergency room, $446,071, a hospitalist of pediatrics, $178,605, a physician OBGYN, $281,775. Based on the report, Madam Chair, I mean, we already know, and based on reports, about 12.5% of all active physicians in the U.S. are internal medicine physicians, according to the Association of American Medical Colleges. When we look at those numbers, it is really on the high end, Madam Chair. And I know that people in this room may argue. And I know that some of the information based on the report was talking about where they get their wage studies. And I know that's from Medical Group Management Association, which, by the way, they guide the amounts, Madam Chair, for PSAs, UEAs, and MOAs. But it also, in their documentation, it also helps doctors to say, hey, you're doing jobs here at these hospitals. Here's how you might be able to get extra work. It's not saying in a bad way that it's a bad thing to go and try to get extra work while being contracted to do work at any hospital in the country or perhaps in the world. But again, the common, I guess, viewpoint of some physicians in this community is the GMHA has some of the highest paid physicians, not just in Guam, but in the country. In another, if I have a little bit more time, Madam Chair, when we think about the approval requirements, and this is a question again to GMH, why do you think that GMHA should not comply with policy 8650.1-207? And is the board expecting to change it?
That policy is a human resources policy that our human resources department is responsible for. It does not apply to physician contracting and hiring and agreements because that is within the purview of the medical staff office. So if you actually look at the top of the policy, it says the area of responsibility is human resources. Human resources handles the hiring and onboarding of most everybody in the hospital that is not a physician. Everything for the physicians is typically handled by the medical staff office. So the medical staff office is governed by the way they do their physician contracting, and that particular policy is one that applies to HR. And so when you're writing a policy for HR, you say all contracts so that one of your HR individuals looks at any contract that they're processing and goes, oh, it's one of these, I need to send it through a process. You're not going to give that same policy to the medical staff office.
Okay, let me interrupt, Jordan, but doesn't HR have to sign off, though?
Not on the physician ones. That's handled in the medical staff office. Because of the dual governance structure, HR handles hiring and all of the support for the physicians, and the HR staff handles pretty much the rest of the hospital.
Okay, that makes sense then. Okay, so then what about training for the medical services or CFO staff to comply with the policy? Are they going to be required to do so? And I was in the audit. Are you guys going to have any training for them?
Really, for who? Sorry,
right.
For which positions need training?
So you just said medical services or your medical training staff, or what? In the audit it mentions training. Are you guys going to do that for them?
Training for the medical staff office.
Relative to the use of these contracts?
Relative to the use of the contracts, we do have training, internal and other things. We have actually increased support for that office in the last several years, including the onboarding of Ms. Sana, who is experienced in that field. We've also offered them an additional staffer with personnel experience as well to handle it. And so we have actually brought in some additional people that have been trained and are exploring options to provide them further training as well.
Sir, I'm sorry, Public Auditor.
If I might, Senator, in policy ALD 700, on the last line of the first paragraph, it very specifically says, the last sentence, the department requesting services through a contractual agreement shall categorize the proposed contracts into one of 6 categories, which include professional services, physician services. And then you go down to the third paragraph. The final signed agreement shall be forwarded to the hospital management administrator, quote, for procurement appeals, or the HR and/or medical staff office for personnel contracts, who will then send it on to the AG, the governor's office. I don't understand that. I kept asking them, where does it exclude the physicians? It very clearly says physicians.
Right, and going with a little bit of experience before the policy was in play, I recall as Deputy Chief of Staff to a sitting governor of Guam, having to see these specific contracts and then making sure that it was on our end process to make sure that it was for final final signature by a governor of Guam. So this is a practice that has been going on for such a long time. New policy, but it sounds like in the execution side, it's just falling short. Let me ask just in interest of time, and I'm just going to...
Excuse, Senator, if I may, I need to correct something that the attorney of the GMHA said that's wrong. Well, I can wait for you to finish your question.
Please.
Yeah, what he said is incorrect. He says hiring is mainly the medical staff as administrator. He does not, the administrator does not need to be signed off, correct?
I don't understand.
You don't understand what you said, or you don't understand what I'm asking?
I don't understand what you're trying to ask.
Senator Sean Gumatauto asked the question that the hiring processes at GMH to you, and you said that's for physician is exempted from their policy. And you said yes, they're exempted from their policy because it's handled by medical staff, correct?
What I said was the policy applicable to the Human Resources Office isn't one that applies to the medical staff office directly.
And then you said, then he asked, did the medical staff office, before hiring, doesn't the administration have to sign off on it? And you said no.
First of all, I didn't, Senator, I did not actually suggest that the administration doesn't have to sign off on it. The hospital administrator does sign off on our contracts. What it does, though, is it goes through a process at the hospital as where the hospital and the hospital administration is the appointing authority into the unclassified service for physicians. I know that different gubernatorial administrations, hospital administrations do have some nuanced differences throughout the years on it, but we have looked for one of the more consistent patterns on it.
So right. What I'm saying is this. The administration does have a direct role in hiring physicians and contracting. Now, the question going back, Senator Gumatauto asked a very good question. The uniform policy in physician compensating physicians. You said, well, that's difficult. We don't know what to do. Let me suggest a constructive criticism here is this. Based on, for example, pediatrics, OBGYN, you can always uniform those contracts. Now, when you have a subspecialist or specialist, a neurosurgeon, for example, you can subspecialize those contracts. But when you're talking about generalized specialty, for doing the same work, you got to make sure that those contracts are uniform and there's no disparity in it. Right now, I've revealed several contracts to you. There's more, by the way. There's not just those 3 that are revealed. There are more contracts that have disparities on it. There's no uniform policy, and there's double dipping. You can always institute a clause in there that you can double dip. If a physician is on call for you 24/7, all compensations by GMH during that time and hour, all work that's done with whatever revenue is brought in should go to GMH. That's not hard to do. But I just want to make sure I clarify that issue that medical staff is not the one that's really holding the key to contracting of physicians.
Thank you, Dr. Shea.
It's the administration. Thank you.
Thank you, Dr. Shea. I just have one more question, Madam Chair. And I just want to say for the record, I was offended reading the audit and the comments of nepotism by the Office of the Public Accountability by GMH and the comments of major deficits in adhering to government auditing standards. For the record, ma'am, this is not the first time that GMH has been through an audit. This is not the first time that the GMH has had the OPA in their building looking at different components of their operations. I think that when we look at if we just look at the report itself, it's plenty important and there's plenty of things to correct. But I take great offense by government officials who would disparage, if you will, the work of an elected public auditor looking at these things. I know they get paid a lot of money to do their work, but so do you. And I think that we should always try to respect the work of other departments and agencies who have a statutory requirement to look at some of these things. I appreciate the opinion, but I'm going to say, Madam Chair, for the record, I was very offended reading that audit. Thank you for the time, Madam Chair.
Thank you, Senator Gumatautau. Senator Duenas.
Titus Masi, Madam Chair, and thank you to the panel and everyone for being here. I know it's going long, but this is very important information that we're trying to get to the bottom of. Just a real quick mention once again by my other colleagues. You know, I completely agree that we have, for several legislatures now, we have been scrutinizing GMH, but we have been coming to the rescue time and time again. In the 37th, most especially, when an oversight hearing basically exploded the multiple issues at the hospital with nurses and other individuals coming forward and discussing the issues, the Republican caucus immediately crafted a resolution that basically said, if you won't declare it, we will. You are in a state of emergency. Subsequently, we passed a bill for $30 million to ensure that you could get out of the hole that you were in with vendor payables. And it's gone on and on and on from there in terms of our appropriations consistently over the last couple of fiscal years. So I just want to make it clear that this body is not here to try to tear you down. We're trying to get to the bottom of the operational issues. And I'm glad that our senator continues to state clearly, our chairwoman, that we can dream about a medical complex all day long. But right now, the people of Guam are faced with a GMH. They really have issues with all the perennial problems. I want to state clearly for the record, because I know this personally, the physicians, the staff, the nurses, they're top notch. No question about it. We go to GMH, when you're treated, you're going to get the best that they possibly have with the resources they have. Now, moving into the purpose for why we're here primarily in terms of the audit. I've heard this back and forth consistently with regard to medical staff hiring versus HR. And I want to put this on the table really quickly because I think this is the disparity that exists here and the misunderstanding in terms of following these contractual hires and what's at play here. First and foremost, I want to say it's not only Dr. Shea, but it is many in the medical community, Dr. Niami and others, that are questioning these practices. This is not whistleblowers coming from individuals who are not educated in the practice and have their own businesses and their models of providing health care. This is your colleagues who are bringing forth these issues and questioning, and they see that the OPA audit, particularly in this area of physician hiring and contractual for multiple contracts within the same building and hospital and multiple duties and responsibilities, seems to characterize now as an issue and perhaps a problem. When we talk about the contractual process where it goes on an RFP and it goes through that whole competitive process, I can understand when you're basically saying that in-house on the medical side, you're basically doing sole sourcing. You're saying you go out and you're getting specialists and you're getting specialties on a basis for which you're going to hire, that it's not the competitive process because of your needs. I think where the problem is that the policy still has to be whereby you have checks and balances. I have done a number of contracts in my time, particularly at Department of Youth Affairs, for services, psychological services and other services, that if you do not have multiple signature blocks that are signed off by ASOs, by the governor, by the attorney general, by management, it is ripe for abuse and conflict. So I want to put this to the auditor. Essentially, you're finding, I'm having a hard time, as you have laid out now, that there is some sort of disparity within a medical office that basically hires on sole source basis and sets up these contracts within their internal policy, sometimes not even a board resolution or a board approval, but just on the fly. I'm thinking what you're saying here is, regardless if you're not doing a procurement for medical services and physicians, if you have an internal contract that you're preparing, you must have those multiple signatures in order to be able to have the checks and balances and the proper procurement of the services. Is that what you're saying?
Yes and no. The hospital insists that the hiring of a doctor is not subject to the procurement policy. They insist that it's the board that determines how the compensation is. I mean, how to hire doctors. And our position is then follow board policy. If any contracts have to go to the governor's office, and it does, obviously, according to both policies from 2018 and 2020, why don't the doctors? And as Senator Gumbertalta said, during his period when he was Deputy Chief of Staff, it was going there. This historical practice, I don't know where that comes from. And I'm not even saying it shouldn't be. Just have it in writing, and if the board approves it, then fine. If the board says it doesn't have to go to the governor's office, I'm not going to challenge it, because the statute says the board determines it. But until you have something that's in writing that's different from the 2018 and 2021 policy, that very clearly says medical and physician contracts, then follow it.
So essentially what you're saying is almost like what I was saying, whether if you're going to move from the process of competitive and hiring and the whole circulation through the procurement process of the contract, then your checks and balances, then the board policy. The board sets the policy, the board waives it, and that's the coverage that they have in terms of procuring these services. Like I said, once again, would you agree that this is basically sole sourcing for physicians for specialties or other reasons?
Yes, it is sole sourcing, and because of the need, I have no objection to that. I mean, I can't question that. But all I'm saying is that the board is supposed to determine the compensation, and unless and until such time as the board changes the policy, all contracts, it says all contracts must be written and follow this procedure. Until I see that, I'm going to question it.
And here's my advice to GMH. I think that we're getting bogged down with the fact that we have a difference of opinion internally with regard to how policy can be set. But I don't think anyone on this panel or anyone in the public or anyone who's scrutinizing the expenditures and trying to make sure that they're in line and there's accountability would disagree with what the public auditor just said. I don't understand why you don't just adopt the policy and come forward and say, we've adopted this recommendation and we're going to ensure that this is how the accountability is going to be manifested. I mean, I don't, this is a funny thing to me, is that I think there's this push and pull, assuming that there's some sort of, charge, for better of a different term, on the management and staff, when I think that's not what's here. What's here is accountability for the process. Because when you're not competitively seeking services, it's open. But some mechanism has to be there so that the accountability is built in. You're not going to get a board to sit and scrutinize and have a contract and approve a contract with their minutes in their meeting if they don't believe that they're going to be accountable as well. And that's what the public auditor is asking for. So I encourage GMH to just embrace this scrutiny and put this procedure in place. I don't even think when you do sole source contract that it'd be hard for you, because you're not dealing with, if the AG has 10 days, the process has 20 days or 30 days to circulate through the process, I still don't think a signature block is wrong for the contract. But if board policy is adequate, then there it is. But I just think the obstinance on this is bad visually, and it's bad policy, and it's bad to accept not presenting, while the LPA said, while there may be a couple of disparities in the audit, I think on this one, for us and for many of us, you need to adopt this policy. I want to move on to something with billing, Yuka, because I've heard this from physicians and so many other people, and this is a testimony from an individual that can be verified in terms of the ER. And this is what's written to me by a constituent that recently had services over at GMH Emergency Room. I personally went to the hospital last week, Tuesday. I advised them that I wanted to pay my bill when I was getting discharged, and the people processing me out told me they could not let me pay because the system was showing I still had insurance. I advised them that I was no longer employed with my prior employer and that I didn't have the insurance that was on record. I wanted to pay it because I knew the fact that I did not have insurance, but they said it was against their policy to accept my payment because of what the system was showing. Loss of money for GMH from someone who was ready and willing to pay right then and there. The other thing I've heard from even individual physicians and others who have helped tourists and others of the like that come through and use the hospital services on an emergent basis, that they cannot pay immediately at the window and they're going to fly away in a couple of days or so. And this is a perennial issue within the ER and accepting payments. Can you address this, Yuka?
We don't refuse payments, so I'd be curious to get the details on the individual that you were talking about, not right now, but maybe offline. We normally do bill the insurance first, but we're able to let the patient know that there's a copay, but we do not refuse any payment. That's not our policy. As a matter of fact, one of the KPIs we're developing for the registration staff is a dollar amount on how much they should collect every month on the self-pay side, which is the copay.
So I will connect this individual to you because I know the person very well, and maybe you have an internal process then where for some reason someone who's taking billing is making this statement, but I want to get it corrected because I know this individual very well, and I know that they did receive these services at the hospital. So
I'd like to correct it as well.
I'll connect them with you. The issue of, in terms of tourists paying. So you're saying it's the same thing. They don't turn them away and say,
no.
we have to generate a bill or whatever?
I know that there have been a few cases where the tourist is leaving immediately. They're leaving that night, they're leaving the next day, and we don't have the bill final. So we normally give them a pre-billing, and then they'll make some kind of deposit, but we tell them to pay online, and they usually do. So once they have the bill and their patient number, once they get back home to their country, they log into our payment portal, and then they can pay online.
Okay, so it's important for me to bring it up because, like I said, if there's disparity internally, we got to fix that.
Yes,
because
I agree.
This individual wanted, so I will make sure that they contact you personally. Madam Chair, my time is almost up, but once again, I highly encourage you to work closely with the OPA in this. I don't think that this was designed for any sort of disparagement. I think it's about accountability and the fact that it is the colleagues in the medical community who are bringing this fact to light, like Dr. Shea and many other doctors and individuals in the medical services. Thank you, Madam Chair.
Thank you, Senator Duenas. Senator Barnett.
Madam Chair, for the opportunity to speak this morning, and thank you for the panel's attendance. Public Auditor. I tend to agree with the retiring speaker in that it's just not a good look for you guys to come in here and debate the findings of the audit. I think the Office of the Public Auditor, the Office of Public Accountability has been doing some pretty bang-up work on these audits. And so for me, we just spent 2 hours going back and forth on whether or not there's a written policy, and there isn't one, which is a little confusing because I would just assume that Human Resources would handle all the hiring. But it seems to me like since we don't have that scenario, it's led to really a lack of accountability for the hiring of physicians. And according to Dr. Shea's testimony, also an inconsistency when you compare one physician to another. Some are getting paid more than others. So I guess maybe, I don't know. And also it's a little weird that you come to these hearings lawyered up. I just can't wrap my mind around that because we don't see that typically with other agencies. But who can answer that question and explain why one doctor who is, of a similar discipline compared to another would get paid more? Anyone?
I will try and answer your question. Again, I've been here for 6 months, but I'll give an example of a pediatrician. So we have pediatricians that only do general pediatrics. And then we have pediatricians that do general pediatrics plus intensive care pediatrics. I don't think it's fair to compensate that pediatrician that only does general pediatrics the same amount of money that a pediatrician that also does intensive care pediatrics. And so what we do is we adjust the pay to make up for the fact that this pediatrician is working at a higher level of acuity. Just like we do for any specialty or any job. If you have more experience or more certifications, you get paid more. So even though the contract may say pediatrician, unless you read through the entire contract, you won't pick up the nuances as to why these doctors are getting paid disparaging. It's not disparaging, it's we're paying for your experience and your work.
Do you believe the lack of Guam Memorial Hospital accountability and contract physician hiring has allowed for dangerous and abusive practices that have resulted in the injury and or death of GMH patients?
I don't believe there's any lack of accountability. I'm sitting here and saying that, yes, I'm at fault for not having a written policy for hiring doctors. There is a historical practice that we follow, but no, I don't believe the contracts have anything to do with medical care or how the care is delivered. I think the two things are separate.
I just think generally in talking with the doctors, the perception is that if you're politically connected, you're going to get a higher compensation than someone who say doesn't have those.
I was born in Ghana, West Africa. I have no politicians. I have no family here in Guam. I love Guam. This is my home, but I don't have any politics. I don't have any Malis or Paris here. That's not why I'm here.
So you mentioned that you were paid in addition to your contract salary, and then are you also the GG1? Are you a GG1 doctor as well?
I am not GG1. I'm an independent contractor. I have a company here on Guam that provides services for neurosurgery to GMH.
Thank you. Thank you for your service. You know, my brother had a stroke many years back, and at the time, there was no neurosurgeon on Guam, and we actually had to wait 3-4 days for him to fly into Hawaii. So, thank you for that. But on top of the money you make with your company, doing business with the Guam Memorial Hospital, is that correct?
So I have an independent contractor agreement with my company through GMH. I am employed by GMH to be its chief medical officer. I will say that that job is not a job that I actively sought after.
Yeah, what's the process
no
that?
one is seeking this job, which
Yeah.
is why there's been so many different positions over the course.
It's just weird that we'd pay somebody $170,000 for a job that, you know, no one is seeking. But you had talked about your qualifications for the job. Do you believe you're qualified to be paid $170,000 annually to be the medical director?
I think I should get paid more, to be honest with you, but I don't want to take from the people of Guam. And so if you look at the CMO job, it actually pays anywhere from $200,000 to $400,000 in the States. So I'm doing this job at less money than what is what it costs. But I believe doing the job not for money, but for the real reasons is important. And so I don't want it to be an incentive that I stay in this job because of pay. Honestly, after my term is over, I don't believe I can continue doing this job. It's a very stressful job.
So you said that you're not paid to be the medical director when you're off island?
That's correct. So I have, so if I'm on vacation, I take either vacation time or I take vacation without pay. So I don't get paid to do it. Even though I am holding meetings off island and doing the job, I don't think it's right that if I'm not physically here on Guam, I should get paid. So just out of ethics, I don't submit my pay sheet.
So do you sign for leave?
So I don't use leave. I leave without pay. So for example, on Friday, I left to go to Mongolia. I was still holding meetings, but I did not get paid for that day because I was not physically here on Guam.
Are you talking about you didn't get paid for your salary of $170,000 as the medical director, or you didn't get paid for your contract work with GMH?
Neither. If I'm not on Guam, I am not getting paid. So for example, if I go to Saipan, Saipan pays me. Guam does not pay me for CMO or for neurosurgery. The only time that I would get paid if I'm in Saipan is if it's an emergency and I fly there to do a procedure and I come back. In that instance, I'm only there for a short duration. But if I'm not on Guam, GMH is not paying me.
So do I take that to mean that although you said on the record you're paid $170,000 annually for your additional duties, that's actually not an accurate total because we have to minus out the days that you're not on Guam?
We do have to minus out the days I'm not on Guam, yes. That's just the salary that I've been given, but that salary is based on the vacation days, the sick days, the retirement fund that I get. So that has to be accounted for by the time that I'm not physically here on Guam. Now, if I do take vacation days, I get compensated for accrued vacation just like any government employee.
Thank you. Mr. Public Auditor, I've never really seen this type of response to an audit where you know, we come into this hearing and there's been the full windup of GMH saying you got this wrong, you got that wrong. But, you know, when you kind of look at some of the issues that Mr. Gerardo brought up, I don't think they necessarily mean that we throw out the audit findings completely. You know, this is reminding me a little bit of some of the audits that you've conducted with the Guam Department of Education where they absolutely refuse to support the findings or even agree with them. But I've never seen it ramped up to this level where we go into a legislative hearing and we have, you know, the management ganging up on you. But do you think this sets a dangerous precedent for your office and the work that you do for the people of Guam?
No. Both Ms. Gerardo and Ms. Hechanova were senior managers of the OPA before. So I'm not above criticism, and neither is the office. If there is, that's fine. But we believe that the objective that we set out to do, the findings that we made, and the recommendations are fully founded and well-founded. That's it. There may be errors in computation, in Appendix 6, but they haven't presented, in fact, they've admitted they don't have a written policy, and the CMO has had to, over the last 6 months, learn the historical practice. All I'm saying is get it in writing so that any CMO that takes over the position will have it in writing on how they treat UEAs, how they treat PSAs, how they treat MOAs, how they treat classified, and address all the other strange nuances of just have it in writing so that it's not left to where people are wondering, how did one doctor get this amount and one doctor get that amount, or this doctor get a contract for this, and put it in writing. And the writings that I have clearly state the medical staff should be in it. They haven't told me where the exemption is.
Yeah.
And so,
It doesn't sound like there's anything in writing, and I know when it comes to auditing, you got to be a real in the black and white.
Senator Barnett, I think, Senator Barnett, this is Dr. Shea. I'm still on Zoom here.
Oh, hey, Dr. Shea.
Yeah, I need to comment on another comment that Dr. Niami, he's my friend, and I have to tell him that what he said was wrong. When he mentioned this contracting, everybody's fair, etc., the contract that I presented exactly goes to the point that what he was talking about. And if you pay attention to my testimony on that one particular contract, he took an example of a pediatrician that's working for NICU or neonatal ICU versus a newborn in a regular nursery or intermediate nursery. That particular contract that I pulled out was actually a family practice physician, not a pediatrician, family practice physician, taking a house call, working for GMH, getting paid $3,600 per day as a family practitioner, taking newborn and nursery intermediate. Another contract with a pediatrician who I've talked to, he's getting paid $2,400 per day. Now, I brought that contract up to him before, he probably forgot, but that particular contract goes to show exactly what the public auditor is talking about. You may not have a policy in writing, but I certainly have these contracts in writing, signed by the CEO of the hospital. I'm sure the attorney sitting there had read it. If he does, you should, because I brought it up to the attorney's office many times that these contracts is not parity across the board. And basically, they just ignore my again, I go back and I think all the senators sitting up there has the right intentions. The intention of the public auditor's audit, in my comments, is not to put down GMH, it's to make GMH better. And they're there trying to defend it. I don't understand why they always come to the legislature or in the public media trying to defend themselves when we're trying here to provide constructive criticism. And I've done that, not in public like this. I've done that personally by emails. I've gone to talk to them. They just don't listen. They're like I don't know if they're taking orders from Adeloop or from somebody else, but certainly that contract that I have in black and white says a family practice is getting paid $3,600, $1,200 more than a pediatrician who's taking the same house call. On top of that, that family practice is also covering their own clinic. How can you cover two clinics at the same time? You're talking about medical errors can occur. You're talking about you can't deliver a baby and take care of the pediatric at the same time. Those are dangerous situations that I've alerted GMH on, but they just don't listen. But what I'm telling Dr. Niami is that he's been there for a few months. I've been there for 28 years, and I've been independent. The other question I have is when you're an independent company, an independent contractor, I didn't know you have retirement benefits or you have benefits of vacation, etc. But certainly if you're an independent contractor and there's a salary, for example, $170 whatever $1,000 there is, I'm sure that $170,000 something salary is broken up by monthly. You get paid every 2 weeks, I assume, or you get paid once a month, or you get paid when you turn in your card, how many hours you worked, etc. But that is something that needs to be also clarified in the policy as well, because right now it's up in the air and no one really knows. But I think one thing that we need to always make sure is that when I speak, I'm not really criticizing or hate GMH. I work GMH. In fact, when GRMC called me to go over to GRMC, I didn't go over. I was loyal to GMH because I wanted to see the patients there. And when they asked me to take call, I said, pay me the same contract that other people are getting paid in that one particular contract that the attorney mentioned that, that was worked out with public health. That's foolish. That's not worked out with public health. It was not. And I asked for the FOIA request on that particular MOU, and they said, we're not going to release it to you. So I would encourage the senators to ask GMH for that particular draft of the contract, MOU. That meeting was made in a press release by the governor's office. It was published in PDN, even KUM, that, we hired this person, and, they're going to be working at public health. Well, it turns out that contract is from GMH. And when I look into those contracting practices, there was something is going on in there that doesn't make sense. And they refused to give me that particular MOU to read. And then I also asked them, hey, if you need help at public health, I'm willing to help. But they didn't take my offer because I didn't ask for any money in return. You go figure, right? GMH has lots of money to blow, but someone who is offering help for zero, they didn't. And by the way, Dr. Niami, bless your heart for saying that. You may not be in that position for long. I offered GMH to be the medical director there 1 year. And I said, you can't afford me. Why? Because I only want to be paid $1. So if the truth be said, if anybody who wants to work for GMH for compassion purpose and because it's out of care for the people of Guam, I have tried that. I said, paid me $1. But all the other medical directors, whatever they're making cost schedules, whatever it is, pay $1. I was turned down for that medical position. So I wanted to let the GMH panel know that when there's a criticism, take it constructively. The attorney's there. Rob Weinberg, I talked to him as well. He gave me so much issues about this FOIA request, etc. Why hide it? You work for the government of Guam. You got to be transparent. Don't try to hide here, hide there. Then you make me wonder what's going on, what's even more. So you want to try to dig even more. I don't have time for all this. I want to take care of patients. I want to see GMH reaccredited. And let's put more effort into that because over the last 6.5 years, I've seen a decline. I've seen a decline in public health and access to care for the entire government of Guam system. So we got to make sure we work together and do it better. Thank you.
Thank you, Dr. Shea.
Thank you,
Barnett, did you want to continue?
Yes, please. Thank you, Madam Chair. Thank you, Dr. Shea. I appreciate that. It's like live fact checking. I was telling Madam Chair that she should have passed out popcorn for this hearing because, and I tell you, I didn't anticipate this. I was, when I read the audit, Auditor Cruz, I was thinking, how can I explain this to the people? And it's almost as if I was elected as a senator and I'm earning money as a senator, and then I get a contract with the legislature to provide the media, and then I get another contract with the legislature to, do the landscaping around here, and then I get another contract with the legislature to do, whatever else. At the end of the day, one of those responsibilities, or maybe even more than one of them, is going to suffer. So that's kind of what I thought. And I mean, Dr. Niame, I'm sure you do the best that you can, but yeah, in my mind, I'm thinking like, how do you run a business, be a neurosurgeon, and then also be the medical director all at the same time? But I guess the moral of the story is kids go to medical school and come apply at GMH because you could get one of the nice contracts. And I think at the end of the day, that's what it's about for me, is dealing with contracting, hiring. There should be consistency across the board. And whether we call it, what was that you called it, Mr. Auditor? Nuances in the hiring of the contracted physicians. I take that to mean, I know Mr. Auditor Cruz really means shenanigans, right? Because that's what it kind of sounds like. Thank you, Senator Taitigui. That's what it kind of sounds like is going on when we have that inconsistency and you have, one doctor contracted to make much more than any of the others. I did want to kind of switch gears here a little bit. So in the last Board of Trustees meeting, chillers were discussed. The chillers were discussed, and I know that In the meeting, you guys had said that chillers had arrived, but there was no money because it was supposed to be paid for with part of the ARP that was taken by the governor's office. Is that still accurate, ma'am?
The chillers have not arrived. We do have a contract. There's two contracts, actually. There's one for the two 450-ton chillers, and then the other contract for the 265-ton chillers. And yes, initially, when we procured them, we initially were going to fund it under ARPA, and unfortunately, that fell through. And so the contracts are still in place. We just need to make sure we have funding to.
Is that why
go
you're
forward.
asking the health chair for, what is it, another $54 million or something?
It's part of the CIP request. However, we are, and we've said this before, where we are looking at other funding sources. So for example, earlier we talked about the grants, and one of the grants there is on the HVAC project. And so we're trying to see if we could at least partially fund some of the chillers, or if not, the 40 AHUs under that DOI funding.
But had the governor not taken the ARP funding, these projects would absolutely be completely paid for.
That is correct.
Okay, what about the maternal child health ward?
So there is still the $15 million appropriation, right, under Public Law 36107, if I'm not mistaken. So that is still intact. We're actually exploring that at the moment because in that legislation, it does allow the use of that funding for infrastructure or maternal child health. And so,
Sorry, you're just stuttering. We can use some of that for CIPs and maternal child health suite, and I think the internal discussions, just to clarify it, has been, since we haven't gotten any bidders on the entire maternal child health suite, is to break down that project, because part of that project also included infrastructure upgrades, such as roof and envelope, so we don't get water into the hospital on those floors. And so to break that project up into some CIP projects, including the wall hardening, roof and envelope, as well as then break it down into starting with the NICU instead of bidding it out as a whole package, because we haven't been able to get the bidders on the whole
So
package.
could you clarify, was the bid for the maternal child health, I remember that you guys had said in the last hearing that was canceled?
yes. So it was canceled because there were no bidders. And so, again, like we reported last time, the idea was that we were going to go back, revisit the scope just to make sure, because what we were hearing from potential vendors was that the scope was too big at the time. And so we just wanted to make sure that, you know, what we're going to put out there, right, for solicitation is something that would be bid upon. And so there were no bidders, to be clear.
Okay. Have you received any advice or guidance from the fiscal review committee that the governor put together to assist the Guam Memorial Hospital? This is the one with the Finance All-Stars?
Specific to the CIPs?
Specific to Guam Memorial Hospital?
We meet every month, but we didn't meet in January. I mean, we didn't meet in February and March. Our next meeting will be in April. And we usually discuss our issues with Medicare, because DOA is helping us with getting the rate adjustment. So that's been the main focus of our topics when we discuss. So we're just waiting to hear back on what we're going to do next with Medicare.
So are these like monthly meetings that
Yes,
you're supposed to be
monthly
having?
meetings.
So why haven't you been meeting?
For some reason, DOA is not able to make, sometimes there's just another meeting that trumps ours, I guess, and it gets canceled, yeah.
So did they give you any advice about your current situation, or you just haven't heard from them in 2 months? Or was the advice asked the legislature again?
No. The main thing is really the Medicare. That's one of our most urgent issues right now, is to get that Medicare rate adjusted. And so because they're the ones providing the consultant for that, that's been the main focus of the topic. We also talk about payables as well. He wants, Mr. Byrne wants to see the payables and the financial reports every month. So I'm sure he reviews them every month. It's just we haven't been able to touch base.
Thank you. Yeah, like one of the retiring speakers has said, it just seems like Groundhog Day because the Guam Memorial Hospital comes to the legislature, then we get you out of one hole and you turn around and dig another one for yourselves. So thank you, Madam Chair. Really, I'm good with the 2 minutes. In case there's any public comment, I don't want to take up any more time. So, si Dos Masi.
Thank you, Senator Barnett. I did want to follow up on something that he asked and something that you had mentioned, Yuka, regarding DOA having a consultant. Why is DOA hiring a consultant to do work on the Medicaid, Medicare reimbursement rate and not GMH?
This is just a consultant, to my understanding, that DOA hired to help them with, I think it's public health issues or something with Medicaid. And so, because this is the same consultant that was used on the rebasing in 2018, this is kind of an additional scope of work that they're giving to him to do the work for us.
And this was when Benita Menglotnia was able to get this. Okay. Thank you. Senator Taitagui.
Si Dos Masi, Madam Chair, and good afternoon to my colleagues. You know, I just wanted to tag on what Senator Barnett mentioned about the chillers. You went out to contract, went out to bid with it. You had the funding, which was ARP funding. So it's been obligated already. So why did they take the ARP funding away from you if the money's already been obligated?
We have a disagreement, and I don't have an explanation for that one from my end.
So, no, well, okay, so now it sheds a different light. You know, you did obligate that money. It just was taken away, and you can't do that when you're procuring anything or trying to go out for contract if you don't have the money at hand. So, you know, I do, you know, while we recognize, you know, the efforts and the contributions made by, you know, this current panel, this management team per se, you know, it's really become evident that there's significant challenges effectively running the hospital and ruining the hospital, and to ensure the institution operates efficiently and provides the highest quality care. We really must explore the possibility of partnering with expertise in healthcare and bring in a management team that can run a hospital. Because I've been sitting here since, 2019, talking about the hospital, trying to move forward with it, and it's getting worse. You know, the Oversight Chair, woman mentioned earlier, when in her opening remarks, the concerns that we have, I mean, it's just so bluntly apparent. It's not getting any better. We have an OPA who's doing his job to ensure that transparency exists, and this administration is doing nothing more but continuing to neglect our current hospital for their aspirations, which is ridiculous because sickness doesn't stop till it's ready for a new hospital to come up, you know, next. It's just ridiculous. There are other options that I have never heard any of you speaking, especially with this salary, almost this one getting $436,000, almost $500,000 for one physician, and that is only on one category. You talked about how physicians are getting paid in different areas of their job, of what they do. And I'm seeing at least 3 so far making almost $500,000 just on one title. Throwing money, you know, to Guam Memorial Hospital is not fixing the problem. We need to look at bringing in a management company to manage a hospital. You know, there are several states that have already introduced a pathway of utilizing internationally trained doctors to come into hospitals. Several states already. We have many of our people in Guam going to the Philippines to seek help. to be seen by doctors there, but we're not allowing it here on Guam. Kind of doesn't make sense, does it? Has anybody thought about that to address the doctor shortage in healthcare? Nobody. You know, securing funding for the EHR system that was mentioned earlier in your presentation, what is the cost for the EHR system currently? What is your cost? Because I'm seeing this timeline is going to take some time, and the longer you wait, the more expensive it's going to get. So what is it right now?
The current EHR we have, we pay about $100,000 a month, so $1.2 million a year.
Okay. But it says here, conduct IT risk analysis and infrastructure assessment, has an arrow going down on that. It's kind of showing are we showing a timeline here?
I was just trying to explain that currently, because the question that keeps coming up time and again is, where are we at with the new EHR? And so what we were trying to explain is that, yes, as we've said in the past, we need a new EHR, but funding is required in order to, we can't even push out a request for proposal if we don't have any funding set aside. So that's part of why we're stuck, right, in the first place. But in addition, the reason why the arrow was pointing there is I was just trying to explain that we're currently trying to conduct an IT risk assessment because in order to us to be responsible stewards, right, of the funds and everything, we want to make sure that, you know, yeah, we have a draft RFP, and yeah, sure, if we had some funding, we can put it out, but is it going to be the right system? That's always the criticism that we get, right, is that, you know, our system is broken. We have problems currently, so we don't want a repeat of the same. And so the reason why we're trying to do a risk assessment is to make sure we get, you know, an independent body to validate that, you know we have problems, but we want to validate what those concerns are.
Well, do you have a timeline on this? Because, you know, we can talk about all these issues and problems, but if there's no timeline, it's just going to be lost in the wind, you know, and no one's going to bring it up again. But it sounds good. It sounds good during this public hearing. But you're never putting in timelines. You're never putting in cost. And that's an issue. So I would hope that you would provide that information to the Oversight Chair, you know, and share that information with us as well. What really is your whole setup? I mean, the cost, you're saying $100,000 a month. You know, what are you looking at? After you finish this IT risk analysis and infrastructure, what's the next step? You know, how much it's, and the timeline. So if we can get that, I mean, I know you're trying to show us development, implementation, secure funding, but there's just no timeline. It doesn't take us anywhere. Okay? So other than that, you know, I mean, my colleagues had a bunch of good questions they brought up, but, you know, one of the biggest questions that we should ask ourselves, is it time? Is it time that we hire a management company to come in to run Guam Memorial Hospital? Because it's obvious, you know, we've been sitting here for years and nothing, it's just getting worse. So thank you, Madam Chair.
Just to respond to that last question, I
didn't ask for a response. I don't think there's anything other than we need a management system unless you have something you want to talk about the EHR. Nothing? Okay. Thank you.
If I may finish to the question, you know.
I didn't have a question. Thank you, Madam Chair.
It started with the question is.
I did not have a question, sir. And right now, you're running on empty with your comments so far. So whatever comes out of your mouth at this point, I don't know if we have to look it up to ensure that you're accurate. So thank you, Madam Chair.
Those are uncalled for. To the suggestion that this is management, we can look to Frank Campillo's recent comment that we could hire Elon Musk, and if 67% of our patients are still underpaying us, it doesn't matter what management team you do there and how good it is, we're still not going to be above float. And so yes, we would like to explore all of these options as well, but it isn't the only thing that's the issue. It is money.
Well, just to reiterate, it does matter. it does matter.
Thank you. Senator Titagui, Senator Parkinson.
Thank you, Madam Chair. Hello, everybody. Been a very long day, very long public hearing, so forgive me if I tread over old ground again. You know, there's been a lot to talk about today. So, talking about internal policies and hiring procedures, from what I've understand in the discussion so far is GMH is exempt from the procurement laws, correct? And they operate independently with their hiring practice. But there seems to be a lack of documentation with those hiring practices. It seems to be one of the cruxes here. So just for my own edification again, could you please remind me, why has GMH historically operated without these specific internal policies regarding hiring and contracting with physicians?
Some of the policies between physicians, it's always been a fluid thing because of the necessity and market conditions for physicians. You know, to the extent that this audit, if this audit would have started with coming and talking to us about our policies, I think we could have cleared a lot of these things up. But what it started with was public comments about what they thought we were doing wrong. Nobody from the OPA actually ever stepped foot inside GMH. And then it ended with a KUAM interview with some disparaging remarks. And I appreciate the public auditor's recognition that he, got a little hot in that moment as well. I've known BJ for a long time, and I appreciate it. I've always appreciated him, and he's actually one of the people that convinced me to stay in Guam after I was done with my clerkship of the Guam Supreme Court. So, but at the same time, we are going to sit here and call it out when we have differences or think they're wrong. And, so that's, but what we've done is looked at the historical practices, and then we've also operated in a way that's consistent with the market conditions and the market rates for compensation. I think if the whole thing comes down to trying to get a board policy that related to what we're actually doing, that's fine. But that really wasn't any of the tenor of the audit along the way, because it started with public comments and ended with with a lot of name calling. So,
okay, the hospital administrator acknowledged a lack of the internal policies, and that you guys are currently in the process of crafting them. What specific timeline do you guys have for that? And can you commit to presenting them to the legislature within a definitive time frame?
So the first step that we have been doing is, and I addressed this a little bit earlier, so forgive me if I'm repeating myself.
Yeah, it's okay.
Our medical staff office is working on getting a comprehensive review of what the practice is now, which doesn't necessarily translate into a policy. It's really just a descriptive what they do on a day-to-day basis with physicians and week to week. And we are also been looking through the forms of the contracts as they are to really make them consistent across the board when they come to the standardized terms. The next step from there will be to sit down internally and potentially work on a policy. This is how all the policies work. And because it's medical staff related and deals with administration at the top, it will have to go through several committees and other things like that. So once we can shore up the description, we can get a better timeline. And we also need to, at the end of a description, really decide whether having a policy or what type of policy is something that makes sense, or if it's something that actually drives up the cost for hiring physicians or inhibits their onboarding as well.
Okay, so it sounds like you have some long-term things in place to get this squared away, but what about in the short term? What are you going to do in the short term to mitigate the potential risk and procedural inconsistencies while all this is being drafted?
First of all, there are very few procedural inconsistencies because, and I think this is one of the surprising parts of this audit. It should come as no surprise that GMH is chronically underfunded and has some struggles when it comes to certain things. Physician hiring and contracting isn't one of them. Recruitment is, but actually getting them on board and started. The medical staff office does an exemplary job at handling all of the facets of that. And so we are looking at the long-term things, but but part of internal controls is really the people that you have. And my auditor experts next to me really described this to me with respect to the audits. And so since we've brought on Ms. Sana and given more support to that office and other things, the internal controls are there to really prevent it, and then it also does go through the medical staff side as well as the administrative side of the hospital, because we really do have two governance structures. We will sit down and take a hard look at these, because we are always looking for ways to improve the health care that we provide and the patient care, but we also don't want to let our bureaucracy get in the way of hiring physicians to provide the direct patient care.
Okay, so let's talk about some of those professional service agreements. Looking at the background here, I see there are 6 sampled contracted physicians found by the OPA auditors to receive a cumulative $12.8 million without having executed required PSAs. That's on page 7 of the executive summary and page 17 of the main report. So the PSA, as I understand it, sets clear terms, conditions, and performance expectations necessary for accountability. But some of the answers I've heard today suggest that there are some, not a lot, but there are some confusions or discrepancies in how contracted physicians are classified or documented. So can you please help explain to me the discrepancy regarding these 6 contracted physicians who did not execute PSAs? Is this a clerical error, or does this indicate a more significant internal classification or documentation issue? Is this kind of a one-off? Like, paint a picture for me here.
So I may give Rodlin part of this answer as well. I think if you're looking at Appendix 6 and those 6 there, first of all, it's actually only 5, because one of them is a directly employed physician. We do still have a number of those. We've moved away from it, but there are some physicians that do work under a GG1 direct employment relationship. So you're really looking at the top 5 on those. Some of the various things with the contracted physicians without PSAs, they may have some other form of agreement, or it might be a late renewal. The other thing too is if you're looking at the surgery group, I believe, is that the group contract? Okay, the surgery at the top was actually a group contract that we had, so the individual physicians weren't actually separately contracted there. They were a part of a surgical group that was offering services and determining their own coverage for certain portions. But sometimes it's a late renewal and other things, but we also govern it by, they only get paid for the time that they actually spend working. If a physician is on a contract and is contracted for 14 shifts a month but only works 10 shifts, they'll only get paid for 10 shifts. So to that extent, it's, we do have accountability and controls on that, because they're not being paid just a set salary every month. They are actually being paid for the time that they're working.
Okay, and how does GMH currently verify the compliance and enforceability of existing contracts in absence of required approval signatures from the AG's office and the governor's office, as indicated by the audit?
And so I think that's one of our areas of disagreement over what approvals are required. We do frequent checks on these things for compliance internally, and one of the biggest checks since we've moved over to a lot of contracted physicians is they actually only get paid for the time that they spend working.
Okay, but if your assertion is that the PSAs do not require external approval, how does GMH reconcile that with your own administrative manual? Policy number 8650-1.207, which explicitly lists these approvals as necessary.
That particular policy, the functional area, and I explained this earlier, sorry if I'm repeating myself again, is in the Human Resources Office. Our Human Resources Office, for the most part, does not handle physician-related personnel issues. Those are handled by our medical staff office. So that policy is written for individuals in the Human Resources Office that are dealing with human resources issues. When it comes to the medical staff office, though, that is not a policy that would apply to them, and when they're looking for medical staff office policies in our policy compilation our policy management system, that would not be one that would actually come up for them either. So when an individual in HR gets it, they will read it and go all contracts, but that's all contracts within HR. That's not all contracts within medical staff office necessarily either.
Okay. Thank you for your answers there. I want to talk a little bit about compensations and fee schedules. So for the people at home, the background, according to the OPA audit, is GMH did not maintain or provide required fee schedules referenced explicitly within PSA agreements. So fee schedules are a tool of public accountability. You know, we have them so that we're transparent and we know what everyone is being paid and for what. These discrepancies and not having these things kind of lead to difficulties in validating whether or not these are fair compensation prices. So why has GMH included the fee schedule clause within PSAs if it is not intended to be followed as per your position?
The fee schedule that's referenced in the contracts actually refers to our charges. So on our website, we're required by the Centers for Medicare and Medicaid Services to post the charges, our fee schedule on our website. So there's a charge code, there's a CPT code, and then there's a description of the code, and then the charge that we charge for the services that we provide and the supplies. So that's what we refer to in the contracts as the fee schedule. So the physician's fees, so depending on what services they provide, there's a CPT code for that, and then there is a corresponding charge that we will charge the patient for that code.
Okay. So I gotta ask, are you guys planning to amend your existing contracts to remove these irrelevant clauses? Or will you guys update your fee schedule so it's a little bit more transparent moving forward?
I don't think there's an issue of transparency on our fee schedule. They're all posted on our website in compliance with CMS, and those are referenced in there that we shall maintain those for the physicians, so when they're providing services at the hospital. The alternative would be to force each physician to write their own fee schedule, and then they charge out their own professional fee. But since we're paying them to provide both the professional fee and the facility fee, it follows the CMS guidelines on it.
The fee schedule that we were referring to is what is the physician going to get paid? As she explained, there's a code and they're going to charge for that. The doctor doesn't get that entire amount. The hospital gets some of it. What is going to be paid to the doctor?
Yeah, that's what I'm kind of unclear about, because it seems like that's kind of a big umbrella that takes into account everything, but it doesn't quite separate what the doctor's getting paid, does it?
CPT codes are a tool used by insurance companies and hospital and healthcare to render payment for services. So if you look at the CMS webpage, you can find out how much a laminectomy is going to cost by typing in the CPT code and also typing in the location. So a laminectomy in Hawaii is not the same amount of money as in Mississippi, because there's also regional difference as well. The reason why CPT codes were invented is that we allow hospitals and clinics and facilities to have the same compensation for each procedure. If a doctor is employed by GMH, GMH keeps all of the billing and collections of that doctor, unless that doctor is seeing a private patient or that doctor is working when he is not employed by GMH. So doctors work in shifts work. So for example, there is a group of 5 general surgeons. Monday, Tuesday, one general surgeon is working. The next 2 days, another one is working. So while that general surgeon is working those 2 days, for the hospital keeps the billing and collections, all of the CPT code. When it's their turn to take off, they may work in their clinic and see the private patients. GMH does not pay that doctor. When that doctor bills the insurance company for that CPT code, they keep all of that CPT code. I think that's the discrepancy, that we think that these doctors are working at the same time for their clinic and for GMH. That's not what's happening. So I think we need to make that clear.
Okay. Let's shift
Hey,
gears.
Senator, can I ask for a clarification on that?
Sure, go ahead.
Yeah, you know, the CPT, so I guess what I'm saying is that, what I'm getting is this. What Dr. Niami said is correct in one term. CPT code is physician code, professional services. Now, what I don't understand is this. Are they saying, is GMH saying that they collect every single CPT code or professional services from the physicians when they're on call for the hospital? I'll wait for the answer.
So if the physician is taking call for the hospital and their contract states that all of their billing belongs to that of GMH, then yes, GMH will collect all the CPT code for that physician. There are some
right, but
doctors,
I'm not talking, I'm not talking about their contract. I'm just talking about, is GMH general policy, or are you saying the contract is different between each physician where they bill for their CPT codes or professional services? And on top of that, they're getting paid by GMH on the same time, on the Guam time.
there are certain doctors that only provide what we call on-call services for the hospital, in the sense that they keep their CPT codes. GMH gives them a call stipend for providing call. But the doctors that are employed by GMH takes all of their CPT collections and code for GMH, and then we pay the doctors for their services. It is very difficult to write a policy that is standard for hiring doctors because of all these nuances.
No, that's not, yeah, well, that's got to be corrected because, you know, when I talk about subspecialists, sure, there can be an exceptions there. But when we're talking about departmental-wise, general specialties, GMH is an essential hospital for general specialty, surgery, OBGYNs, pediatrics, family practice, whatever you may want to call it. Those contracts should be uniformed. You can't say you're paying one OBGYN $4,800 a day, on the same time they're working for another clinic under Guam time and they're getting paid another couple $1,000s a day. That CPT for that professional service for the time that they spend in hospital for government Guam goes to government Guam. GMA should collect that. That's why I'm suggesting that to whoever's the financial person at GMH is. You're losing money. The bucket is full, but you have full of holes in there. And that's what the audit is trying to tell you too, is that you got to capture those revenues for GMH. Now, the point, you know, I think that the attorney said, Elon Musk, you can't hire Elon Musk that comes in and he wouldn't be able to do anything. Well, I beg to defer that. I think if Elon Musk comes in as CEO, I think he will clean house and trim the fat. The reason to say that is you can't compare yourself anymore as the only hospital on Guam that accepts all patients. You have GRMC that also accepts all patients. You know, so GRMC serves almost the same population as the entire island of Guam. You can walk to GRMC and get care. They can't refuse care, same as GMH. So GMH used to be the only hospital here in the civilian sector, but no longer the case. So the 70% of non-payers also can apply to over at GRMC. So the excuse that, hey, 70% non-payers, they come to GMH, that's why we need a supplemental funding. I don't see us giving supplemental funding to GRMC. So I think what we need to do is take a step back and look at our finances and look at which holes we can plug up. And this is where the legislature is coming asking these questions. And I'm not here to, you know, I'm spending 4 hours sitting here on Zoom to listen, but I also want to make sure things are carried through correctly, the information is carried correctly. And I have a lot of experience walking to GMH. On that table, I'll probably add up more years than all of you add together. And I see Shauna, I think Brenda is sitting in the back. Brenda knows exactly what I'm talking about as well, as far as physician contracting. So I think we need to be honest and transparent and how to plug up these holes so that GMH can be more independent. Thank you.
Okay, so let me switch gears a little bit here to unclassified employment agreements, UEAs, and staffing patterns. On the background, I see that 30 out of 32 GG1 physicians, including management, did not execute required unclassified employment agreements with compensation totaling $25.5 million. For me, this raises a little bit of an accountability issue because GMH claims administrative positions are governed by position descriptions and appointment letters rather than UAE, but these positions nonetheless involve public funds. So I guess my question is how does GMH currently establish and verify salary benefits for GG1 employees, physicians, that also occupy managerial or administrative roles without formal contracts?
I believe the CEO has the power to appoint leaders of the hospital. I believe that's Title 4. I forget, but GCA code allows the CEO to appoint leaders in the hospital, both for nursing, respiratory, pharmacy, and also the medical staff. And so this appointment is how these directorships are appointed, in the sense that...
So it's discretionary?
I don't know if it's discretionary, but in order to have a functioning hospital, you need to have leaders. As a matter of fact, with the CMS, these leaders have to be physicians. For example, you need a nephrology director to be a nephrologist. You need a physician to be in charge of respiratory. This is something that comes from federal mandates. So I wouldn't say it's discretionary, but it's something that the CEO has appointed power to do.
Okay, but it seems discretionary to me from the way you describe it. So I guess that leads to my follow-up question. What mechanisms does GMH have in place to control or review this not discretionary salary adjustment? Like, what is the mechanism there, considering that there is a lack of unclassified employment agreements?
There's a description of the job and appointments, and so if you don't meet the job description, the CEO can reappoint another person if you don't meet the qualifications. So that is the checks and balances we have.
So it's a question of efficacy then. If they're effective, if they meet the standard, then it's all good.
So, for example, if you're a director of nephrology and you lose your nephrology license, you are not eligible to be director of nephrology. If you're a director of respiratory and you lose your license as a physician, you cannot be the director of respiratory. But there's, in addition to the qualifications, there's also the job duties you have to meet. You have to be able to go to the meetings, you have to be able to do the peer review, you have to be able to discuss with the suppliers and plan for the future. These roles don't just happen. You have to actually put work into it.
No, I understand. I'm just saying that $25.5 million is a significant number for something to be what seems to be a high level of discretion on the hiring. There's with no clear documentation. $25.5 million is bigger than entire branches of government here. And this is just for 30 employees. So can GMH confirm and provide evidence that all these GG1 physicians' compensation align with the approved staffing patterns and current budgetary allocations?
I would have to go back and look at the audit. Again, I've been here only 6 months. Not an excuse, but I'm just trying to understand how GMH practices. But I think some of these things need to be looked at and discussed because the report did have errors as far as duplications, and I think that's why the number is inflated.
Okay. Yeah, no, because Yeah, it is a very big number. So let me talk about...
So just to clarify that number, though, it is a number over 4 years that's been consolidated into one column. So it isn't $25 million in 1 year. It is $25 million according to the report over the course of 4 years.
Thank you. I appreciate that clarification. Thank you. And then another thing I wanted to talk about was locum tenens physicians and MOA approval compliance. Looking at the background here, I see that there were 28 MOAs that lacked required approvals, and they kind of highlighted some procedural lapses. This could be found on page 9 of the executive summary or 23 to 24 of the full audit. So my understandings about MOAs is they provide the flexibility in urgent hiring situations, correct? But you still need to maintain some consistency to internal approval processes to make sure that this money doesn't get used in poor ways. And correct me if my understanding of this is wrong, and a local tenens physician is a medical doctor who temporarily fills in for another physician who is absent or when a healthcare facility is short-staffed. So the term locum tenens is basically, it's a placeholder, correct? Is my understanding the concept of the locum tenens physician correctly?
It is a placeholder. Oftentimes, we're able to get the locum tenens to be a permanent physician if they like the job and the island and they are a good fit for the hospital and if they do a good job. But yes, the reason for locum tenens is that we have an urgent need to fill a position. For example, we lost a pathologist. We needed one in order to meet CMS guidelines. And so we had to hire locum tenens to fill that gap until we can find a permanent pathologist.
Okay, so in this situation, why were required signatures from the Attorney General and Governor's Office not obtained for MOAs despite clear internal policies mandating such approvals?
Again, I think there's disagreement over the required approvals. Those aren't required approvals for appointments to the unclassified service. As to our locum tenens, we typically do have some sort of agreement with I say staffing agency that goes out and finds the physicians for us when we do need a locum tenens, and then when we are engaging that particular person for the limited period of time, our medical staff office has prepared an MOA to outline the duties and compensation and other things for that emergency or short period.
Okay, so for these placeholders, what internal checks does GMH have to make sure that they're doing things like adhering to payroll reporting, or they're actually delivering their services or agreed compensation terms? What are your internal checks to confirm all those?
Our medical staff office, for example, regularly double checks the timesheets and other shifts worked by our physicians and keeps very detailed records of those. And we'll submit those either over to the finance department or, when appropriate, the payroll department in some instances, but it usually gets handled by finance and accounting. And they will make sure that those get paid out. So you will have the review of the medical staff office. You'll have the review of either accounting or payroll, somebody in the finance department. You'll have the review of the CFO when it comes to certifying funds available. You'll have the review of the chief medical officer, and if there are actual performance-based issues, either the department or the medical executive committee can step in to review them as well. We have a very robust governance structure for medical staff. I know that sometimes it seems a little esoteric to some, but we do have privacy rules that prohibit us from getting on about specific cases or issues, and so, but we do have a long list of checks that this has to go through, and our medical staff office does an exemplary job, and they really are those frontline people that come in and show up and actually are probably underpaid themselves to do all the work that they handle, from physician hiring to coordinating peer reviews to committees to federal reporting about physicians. They really handle it all, and so the internal control really starts with our people, and that medical staff office is that front line that does an exemplary job, and we have multiple layers up from there.
Do you think your internal controls thus far are doing a good job?
On physician contracting and keeping records of pay and hours worked, I think our medical staff office is doing one of the best jobs that I can ever imagine. I actually routinely tell Ms. Sana and her team that they're actually not one of they're one of the departments that I never have to show up in, and so usually when the lawyer shows up at your door, it's there's something that needs to be fixed, and I rarely have to show up in that office to fix anything. I'm usually over there for their cookies, not their problems.
Okay. GMH's financial position has significantly worsened over the years, from $247 million in fiscal year 2020 to $298.4 million in 2023. That's about a shortage of about $50 million, is from what I understand. To balance a budget, you either had to cut operating expenses or raise revenue. How are you cutting operating expenses or raising revenue? What's the plan?
Our revenue strategy is really to tackle the Medicare and Medicaid reimbursement rate right now. We're pretty aggressive with all of the third-party payers. We send them their receivable reports every week and demand payment. But it's really on the revenue side is addressing that shortfall from our 65% of our patients are covered by Medicare or Medicaid, and so we want to get as much as we can from that reimbursement.
What about on the other end? How is GMH addressing the financial impact of these procedural deficiencies identified by the audit to the tune of $105 million? That seems like there's some fat to cut there and close that $50 million delta.
As far as the deficiencies in finances, if you actually look at the report, there were $0 in question costs in the audit. It was the procedural things that actually don't necessarily drive down any of the costs. I've looked at their question cost charts and the financial impact. But what it is it really is what they've engaged in as a performance audit where they're questioning our internal controls. We have fundamental disagreements and we firmly disagree. I'm not going to sugarcoat it any other way. But at the same time, when it comes to costs and certain aspects of the audit, I don't think they've actually yet questioned any of the direct costs, according to the report.
I know I'm out of time, but Madam Chair, may I ask my last two questions? I just have two more questions and I'm through. Okay. Has GMH done any internal cost-benefit analysis if it's better to contract doctors versus hiring them directly?
There was some internal assessment done several years ago in which it was, there are advantages to having both options available because certain physicians do prefer different options. That is something that's ongoing because we do have, we do programmatic reviews and things periodically, and so we do have, we have that on our list of, periodic list of things to review. But it has been, we have had success in recruiting physicians, especially in some areas in which Guam hasn't had physicians in the past. You have some examples of that, Dr. Naimi.
So unfortunately, there aren't enough doctors on Guam to have a choice of whether you want to contract them or hire them. So we sometimes, well actually all the time, is preference from the doctor who wants to provide services to GMH. Because of the lack of physician shortage, depending on how they want to structure their contracts and the needs of GMH is how doctors are hired. If I had it, I think it would be better to contract with a physician rather than hire, because when you hire the physician, you have to pay their insurance, you have to pay their retirement, and so you spend more money.
So this is the cheaper option.
Exactly, it's cheaper. So I always try and force them, not force, but plead with them to do the independent contractor because we save money.
Okay, and last question.
Sorry, can I just give you a visual for it? If you actually look at even page 12 of the report, there's a table 1A and a table 1B that actually differentiates between the medical staff costs in the personnel, which would be our GG1 medical staff costs, and then the contractual services in table 1B, which would be our contracted physicians. you see an increase in the contractual services column, but at the same time, in the last 3 fiscal years audited, you see a significant decrease in the GG1. So as there is somewhat of an increase on the contractual services, we do have a concomitant decrease on the other side. So it's not just a ballooning cost, it's a shifting from employee to.
Because that kind of leads to my last question, is how does GMH reconcile these recurring financial deficits with physician compensation, especially given that the increases in contractual services expanded from 12.4 million in 2020 to 25.3 in fiscal year 2023. So you said there's a shifting. Is there anything else that accounts for it?
Yes, and there's a little bit that accounts for it, but even just looking at the difference between year 1 and year 4, if you add the medical services together, that from both the GG1 and then the contractual services, it actually is only about a $7 million increase across 4 years. Part of that is also accounted for because in the early years, especially if you look at some of the personnel costs in 2021 and 2022, there were COVID differentials and other things that came into play, and long hours.
Temporarily,
yeah. The problem that we're having is some of those temporary increase in costs of services and goods have stuck around long after COVID. So we're not, given that inflation has significantly risen, the costs of goods, supplies, and other things has risen. And then people across the board in the labor force require more money. Guam's not a cheap place to live, and so we have to pay competitively. And we're also competing against the stateside doctors whose salaries have also risen. Just picking a number, if it costs $1 million to hire a particular specialist, it costs $1 million because they can go off to the States and maybe live somewhere with a lower cost of living and make more money, because we're following the national guidelines on compensation, but we're actually often slightly below it. Not in every case for every specialty, but that's because we get some of these things that are very difficult to recruit. And also on the paying for the administrative costs, the physicians that take on the administrative duties get paid on that separate thing. That helps us differentiate our administrative costs from our medical costs, which help when it comes to reimbursement through Medicare and Medicaid, because we are required to differentiate those things. And the physicians that are doing those duties would otherwise probably be demanding their clinical rates and their hourly rates under the equivalent hourly rates under the administrative positions, whether it's an appointment or an agreement, typically are lower than what they would be getting on a regular medical shift.
Thank you for those answers. Thank you, Madam Chair. I appreciate the extra latitude.
Thank you, Senator Parkinson. Is there any member of the public that wanted to testify or ask any questions? And if not, I just have just a couple of questions to follow up on what was said today. Dr. Naomi, earlier you mentioned that we have things at GMH doing things outside the standard of care. Can you clarify what you meant by that?
I apologize if I said that. No, we are doing things within the standard of care. I say that sometimes things fall outside of standard of care, but it's not that we're doing it on purpose. Mm-hmm. It's that with any healthcare system, there are things that will fall outside of standard of care. When we catch those things, we immediately get together and fix it.
What are some of those things that you've caught in the past then?
There are things like the fact that the building is unsafe because of the issues of not having up-to-date maintenance and the CIP projects. There are things that my concern especially is if another typhoon happens, this building I don't think will withstand it. They're not medical things, they're structural issues that I think are having safety issues. But the same thing that we're talking about, that this building is just not current and that we need a new facility or we need to upgrade it.
Mm-hmm. What about instances where, what about medical standard of care?
As far as medical is concerned, we meet standard of care. It's outside of the medical I'm talking about as far as the building and structure.
Mm-hmm. So I did want to follow up on what happened not just over the weekend with the female that was found dead inside the courtyard, but the incident that happened on February 5th regarding the elderly man. And there is a picture that we have, because I'm trying to understand how this could have happened. And I think it's only right that the family have an explanation as to what has happened. And that is not, as I understand, not an active GPD investigation, because GPD went out there and the family is not happy with what GPD told them, because they feel as though there wasn't a thorough investigation. Because, do we have the picture? Okay, this is the picture. The old man, he's 75 years old. He was supposedly discharged, but the family had no messages on their phone that there was a missed call. So they were called, I believe I said 2 o'clock in the morning. The elderly man managed to open the metal doors in the ER, wheel himself down, went over that speed bump that you see right there, and then he was found where the X is, in front of the security checkpoint, hours later. I was looking at your staffing pattern. You guys have about 37 security guards. Do they work 24 hours, or any of them? What are their shifts, and how come nobody saw this old man in a wheelchair going down this incline and over a speed bump and died in front of the security checkpoint? Can anybody answer that? Mr. Zaldi, you are the acting CEO, although it seemed like Jordan was. Are you getting paid for that?
No, I get paid my regular salary no matter how many hours I work. I'm an
Can
exempt
somebody
employee.
answer?
The reason I'm speaking up here is because, to the extent that it involves a specific case, HIPAA does prevent us from commenting on that. We have to follow patient privacy rules. I know the issues with it, but the law clearly requires either a signed consent from a particular patient to discuss a case, or a court order or subpoena signed by a judge or judicial officer. So without that, we really just can't comment on things like this.
Will somebody talk to the family and let them know? Because they're calling us, they're calling me, they're calling the media, wanting answers. I can give you the phone number if that'll help.
I'm happy to take the phone number. There is sometimes we're limited in what we can discuss under federal law, but we will give a consideration and speak to the family to the extent that we are legally permitted to do so.
Okay, thank you. I do have one other question, and this comes from a concerned vendor. I have been supplying GMH for more than 2 decades. They are very demanding when it comes to receiving their orders, but are never quick to reply when my office follows up for payment. There is not even an attempt to arrange even small payments to help lower the amounts of long-standing invoices. It's gotten to the point where it is not profitable doing business with the hospital, because whatever small profits we receive are used to pay bank interests, which are now 9.5%. How does GMH handle the scheduling of payments?
It's based on cash flow. It's just whatever we collect and the urgency of the payment. I will admit that when we have follow-ups from the vendors, I do tell the staff to please, because they're assigned, I have a very small accounts payable staff, and they're assigned 50 or 100 vendors each. So I try to make sure that they at least respond to the vendors and let them know that when they'll get paid, how much they'll get paid, and not make any promises that we can't keep. But it's been a cash flow issue. That's what our problem is.
Thank you. BJ, can you give us an idea when the next part 2 will be coming out and what it will be focusing on?
It'll probably be out by the end of the year. And it will go in depth into the contracts themselves.
Okay. And will there be meetings that, will you be having any meetings with GMH on this?
Oh, yes.
Okay. Thank you.
They're not all traveling.
Thank you. And just in closing, just based on conversations and meetings that I've had with GMH, I strongly urge you to prioritize and expedite your grant proposal for the $500 million in CBDBG DR funds to support your capital improvement projects. We talked about this over a month ago, and yesterday you mentioned that you were still gathering information and haven't even started with the draft yet. So I would hope that you guys would work with more of a sense of urgency. Rodelin, did you want to say something? Okay. Since the informational briefing, I've been committed to addressing your procurement concerns and will continue working with you on this matter. Jordan, I'm just waiting for you to send me the information on what laws you think need to be amended. As requested over the weekend, I will collaborate with Congressman Moylan to pursue that critical access hospital designation. During my visit to the skilled nursing facility, GMH expressed interest in potentially leasing out that facility for revenue generation. And as I mentioned during that meeting, I'm ready to assist with legislation if it is required. At your request, I also shared my commitment to exploring opportunities for collaboration between GMH and public health to optimize underutilized spaces, such as the Community Health Center in Inalahan as an urgent care facility to help alleviate the strain on GMH's emergency room. And again, while I am committed to working with you to find solutions, I expect GMH to take proactive and decisive steps to improve its operations. Again, thank you so much for being here. Thank you to GMH. Thank you, Public Auditor. It is now 1:02 in the afternoon, and this oversight hearing with the Committee on Health and Veterans Affairs is adjourned. Thank you.